Tonight is all about slowing things down. Find a comfortable position, let your body relax, and just listen. We're going back in time, to the Second World War. We're going to look at the people who helped. The doctors working in tents, the nurses carried stretchers through mud, the medics run toward wounded soldiers instead of away from them. In the middle of one of the most destructive wars in human history, these men and women showed up every single day, with bandages, with medicine, with steady hands, and they did everything they could to keep people alive. This is their story, and it's a gentle one. So breathe slowly, close your eyes if you like, and let these quiet acts of courage carry you through the night. Fact number 1. At the very front of any battle, before a wounded soldier could reach a doctor or a hospital, there was usually one person who got to him first. That person was the combat medic. In the American Army, medics were trained soldiers who carried weapons but whose main job was saving lives, not fighting. They moved through active battlefields, sometimes crawling, sometimes running, to reach men who had been shot or hit by shrapnel. They carried basic supplies, bandages, morphine for pain, plasma to help replace lost blood. Their job was not to fully treat a wound right there on the battlefield. Their job was simpler than that. Stop the bleeding, ease the pain, and get the soldier moving toward proper care as quickly as possible. In the American Army alone, tens of thousands of men served as combat medics during the war. Many were killed doing this work. They were not always armed. They were not always protected. But they showed up anyway, in every theater of the war, Europe, the Pacific, North Africa, and the soldiers who survived because of them never forgot their faces. Fact number 2. When large numbers of wounded soldiers arrived at a medical station at the same time, doctors faced a very difficult problem. There were more patients than they could treat all at once, so they had to make a choice. Who gets help first? The system they used was called triage. It came from a French word meaning to sort. The idea was that doctors would quickly look at each patient and sort them into groups. Some men had minor wounds and could wait a little while. Some had serious wounds but would survive if treated soon. And some, sadly, were so badly hurt that saving them was unlikely, no matter how much time was spent. This was a hard system. It asked doctors to make painful decisions very quickly, often under enormous pressure. But it worked. Without triage, medical stations would have been overwhelmed, and far more men would have died. By the time of the Second World War, triage had been carefully developed from lessons learned in the First World War. Every major army, American, British, Soviet, German, used some version of it. It was never easy, but it saved lives every single day. Fact number 3. Before the war, one of the most dangerous things about being wounded was not the wound itself. It was what came after. Infection. Even a small injury, a cut, a graze, a bullet wound that missed anything vital, could become deadly if bacteria got in and spread. Surgeons in earlier wars had watched countless men survive their injuries only to die days later from infected wounds. By the Second World War, doctors had a new tool that would change everything. It was called penicillin. Penicillin had been discovered in 1928 by a Scottish scientist named Alexander Fleming, but for years it was very difficult to produce in large quantities. When the war began, American and British scientists worked together to figure out how to make it in massive amounts. By 1943, they were succeeding. By June 1944, the time of the D-Day landings, there was enough penicillin to treat every wounded Allied soldier. The difference was remarkable. Men survived wounds that would have killed them just 2 or 3 years earlier. Infection rates dropped sharply. Penicillin became one of the most important medical tools of the entire war, and its story began right there on the battlefields of the 1940s. Fact number 4. Losing too much blood was one of the fastest ways a wounded soldier could die. Even a wound that wasn't immediately fatal could turn deadly if the body lost more blood than it could handle. The challenge was, how do you give someone else's blood to a wounded man in the middle of a war? Doctors had been working on blood transfusions for years, but the war created an urgent need for a solution that actually worked at scale. The answer came in 2 parts. The first was whole blood, donated by millions of civilians and soldiers, typed, stored carefully, and transported to hospitals near the front. The second was plasma. Plasma is the clear liquid part of blood, separated from the red blood cells. It could be dried into a powder, packaged easily, and mixed with sterile water when needed. Because it didn't contain red blood cells, it could be given to any patient regardless of blood type. Plasma helped keep blood pressure stable and gave the body enough fluid to function until surgery could happen. The United States set up enormous blood donation programs. Britain did the same. Plasma kits were carried right to the front lines, and the results, men surviving blood loss that would have killed them before, were profound. Fact number 5. When a soldier was wounded on the battlefield, getting him to proper medical care was not a single step. It was a journey, a carefully organized chain of stops, each one offering a little more help than the last. It started right where he fell. A combat medic would reach him first, stop the bleeding, give morphine if needed, and mark his forehead with the letter M if morphine had been given, so no one would accidentally give him a second dose later. Then the soldier would be moved to an aid station, which was close to the front, maybe just a few hundred meters back. There, a medical officer would do a little more, stabilize the wound, check the patient's condition. Then the soldier would travel further back, by stretcher, by jeep, by ambulance, to a field hospital where more serious surgery could take place. And from there, if needed, on to a base hospital far behind the lines, or even home to his own country. This system was called the chain of evacuation. When it worked well, it was one of the most effective things the military had ever organized. Every step of the chain had one purpose: keep the soldier alive long enough to reach the next one. Fact number 6. In the Pacific, the American Marines had their own version of the combat medic. He was called a Navy corpsman. These men served alongside Marine units on some of the most brutal battlefields of the entire war, landing on beaches under heavy fire, moving through thick jungle, treating wounds in heat and rain and mud. The Pacific was a particularly dangerous place to be wounded. The tropical climate made infections develop faster, insects spread disease, clean water was often hard to find. Corpsmen carried sulfur powder, an early antibiotic, to dust directly into wounds to slow infection. They also treated diseases that were nearly as deadly as the fighting itself: malaria, dengue fever, dysentery. On the island of Iwo Jima alone, Navy corpsmen were awarded 27 Navy Crosses for bravery. 4 corpsmen received the Medal of Honor during the entire war. Marines had a saying about their corpsmen, that they would follow them anywhere and trust them with their lives without hesitation. That trust was earned the hard way, in the worst conditions imaginable, on islands most people had never heard of before the war began. Fact number 7. The Soviet Union fought the largest land war in human history on the Eastern Front, and its medical system had to keep up with casualties on a scale that was almost impossible to imagine. In the early months of the war, after Germany's sudden invasion in 1941, the Soviet medical system was badly disrupted. Hospitals were overrun, doctors were captured or killed, supplies were cut off. It was a desperate situation, but the Soviet Medical Corps adapted. Mobile surgical units were created, small teams that could travel quickly and set up field operating rooms within hours. Soviet women served as nurses, doctors, and even frontline medics in roles that other armies reserved only for men. By the middle years of the war, the Soviet army had trained over 700,000 medical personnel. Over the entire course of the war, they treated approximately 22 million military casualties. Of those, more than 70% were returned to active duty, meaning they recovered well enough to fight again. That recovery rate was considered remarkable, even by Allied standards. It was built on improvisation, courage, and an enormous amount of hard, quiet work done by people whose names history rarely recorded. Fact number 8. Germany began the war with a military medical system that was by most measures very good. German military doctors were well trained. Their equipment was modern. Their procedures were organized carefully, drawing on lessons from the First World War. In the early years, during the fast campaigns in Poland, France, and the opening stages of the Eastern Front, the system worked as intended. Wounded men were evacuated efficiently, surgeries were performed quickly. The mortality rate for the wounded was low, But as the war went on and Germany's situation became harder, the medical system began to suffer. After the catastrophic losses at Stalingrad in 1942 and 1943, hospitals inside Germany itself were overwhelmed. Supplies grew short, doctors were exhausted. The trains that carried wounded soldiers home were targeted by Allied bombers. By the final years of the war, German military medicine was struggling to maintain the standards it had once been proud of. The gap between what the system had been at the start and what it had become by the end was a quiet but telling reflection of how badly the war had gone for Germany as a whole. Fact number 9. Under the rules of war agreed upon before the conflict began, hospital ships were supposed to be protected. These were large vessels, painted white with big red crosses, that sailed through dangerous waters carrying wounded men away from battlefields and back towards safety. Both sides had agreed not to attack them, and for the most part, that agreement held. British hospital ships helped evacuate thousands of wounded soldiers from the beaches of Dunkirk in 1940. Hospital ships served in the Mediterranean, the Pacific, and the Atlantic throughout the war. They were staffed by nurses, surgeons, and medical orderlies who worked around the clock, often performing surgeries at sea while the ship rolled through rough waves. The work was hard and the conditions were difficult. But these ships represented something important, a shared agreement, even in the middle of a terrible war, that the wounded deserved care. Not every agreement was honored perfectly. There were incidents, but the hospital ship system in general functioned as a rare example of humanity finding a way through. The men who were carried home on those white ships, looking up at the red cross painted on the hull above them, knew they were going to be all right. Fact number 10. Nurses played an enormous role in the medical effort of the Second World War, and their story is one of the quieter heroisms of the entire conflict. In the United States alone, approximately 59,000 women served as army nurses during the war. Thousands more served with the Navy. They worked in field hospitals close to the front lines, on hospital ships at sea, in base hospitals far behind the lines, and in operating rooms where surgeries went on for hours at a time. They were not supposed to be in danger. But war does not always follow the rules. American nurses were among those captured by Japanese forces in the Philippines in 1942, where they spent years as prisoners of war. Nurses served in North Africa, in Italy, in the Pacific Islands. They were present on the beaches of Normandy within days of the D-Day landings. British and Australian nurses served in equally difficult conditions. Soviet women served as frontline medics and surgeons. What all these women shared was a steady, unflinching commitment to their patients, men who were frightened and in pain and far from home. The presence of a nurse, in many accounts written after the war, was described as one of the most comforting things a wounded soldier could encounter. Fact number 11. One of the most common injuries of the Second World War was caused not by bullets, but by small, fast-moving fragments of metal from exploding shells, bombs, and grenades. These fragments were called shrapnel, and they could travel enormous distances from an explosion and cause wounds of many different sizes and shapes. A shrapnel wound was often more complicated to treat than a bullet wound, because the fragments were irregular in shape and could travel unpredictably through the body, sometimes stopping in places that were very difficult to reach surgically. Military surgeons spent a great deal of time during the war learning how to deal with shrapnel injuries, when to remove fragments and when to leave them in place if they weren't causing immediate harm. X-ray machines, when available, were used to locate fragments inside the body. In the field, however, X-rays were not always an option, and surgeons often had to work by feel and experience alone. It is estimated that shrapnel caused the majority of combat wounds in the European theater, more than bullets did. Understanding how to treat these wounds quickly and effectively was one of the central skills of wartime surgery, and it improved steadily as the war went on. Fact number 12. Malaria was one of the most serious medical problems faced by Allied forces fighting in the Pacific and in parts of North Africa and Italy. It was not a battlefield wound, it was a disease spread by mosquitoes, but it could take a soldier out of action just as effectively as a bullet. In some Pacific campaigns, malaria casualties outnumbered combat casualties. On Guadalcanal in 1942, for example, Nearly every soldier who served there contracted malaria at some point. The disease caused high fever, shaking chills, extreme fatigue, and in serious cases death. The standard treatment at the start of the war was quinine, but supplies were limited. Japan had captured most of the world's quinine-producing regions early in the conflict. American and Allied scientists worked urgently to develop synthetic alternatives. Atabrine, also known as mepecrine, became the main substitute. It worked, but it turned the skin slightly yellow and caused nausea in some soldiers, which made many reluctant to take it. Military commanders had to issue strict orders requiring soldiers to take their atabrine daily. Over time, the rates of malaria came down, but throughout the Pacific War, the disease remained a constant, draining presence that the medical corps fought every single day. Fact number 13. Surgery in a field hospital during the Second World War was nothing like surgery in a peacetime hospital. The operating room might be a tent. The lighting might come from a single lantern or a generator that could cut out at any moment. The floor might be dirt or wooden boards laid over mud. Surgeons worked in their uniforms. Nurses handed instruments across makeshift tables. Outside, the sound of artillery might be a constant backdrop. And yet, in these conditions, surgeons performed extraordinary work. They removed shrapnel, repaired damaged organs, amputated limbs when there was no other option, and stitched wounds that in peacetime would have required a fully equipped hospital. Speed was essential. In a busy field hospital, a surgeon might operate on 20 or 30 patients in a single shift. Techniques that would have taken hours in peacetime were condensed. Decisions were made quickly, based on experience and instinct as much as textbook knowledge. Many surgeons came out of the war with a level of skill and speed that no peacetime practice could ever have produced. It was hard-won knowledge, earned in the worst possible conditions, but it permanently advanced the art of surgery in ways that benefited patients for decades afterward. Fact number 14. One of the lesser-known aspects of wartime medicine was the treatment of burns. Burns were common in this war in ways they had not been before, because of the widespread use of aircraft, tanks, ships, and incendiary weapons. When a plane caught fire, or a tank was hit and burst into flames, the men inside faced severe burns that covered large parts of their bodies. Treating these burns was extraordinarily difficult. The pain was intense, the risk of infection was very high, and the long-term damage to skin, tissue, and appearance could be permanent. A British surgeon named Archibald McIndoe became famous during the war for his pioneering work treating burned Royal Air Force pilots. He developed new techniques for skin grafting, taking healthy skin from one part of the body and using it to cover burned areas. He also understood that his patients needed psychological support, not just physical treatment. He created a warm, supportive environment at his hospital in East Grinstead, and his patients, who called themselves the Guinea Pig Club, formed a lifelong bond. McIndoe's work laid the foundations of modern reconstructive surgery and helped hundreds of men rebuild their faces and their lives after injuries that would otherwise have been devastating. Fact number 15. Amputation, the surgical removal of a limb, was one of the most common major procedures performed during the Second World War. When a limb was too badly damaged to save, or when infection had spread too far, amputation was sometimes the only way to keep a soldier alive. Military surgeons had learned from previous wars that early, clean amputation, done quickly before infection could spread further, gave patients the best chance of survival. By the Second World War, surgical techniques had improved significantly. Anesthesia was more reliable, surgical tools were better, and the procedure itself was performed more skillfully and quickly than in previous conflicts. Still, losing a limb was a life-changing event, and the men who went through it faced a long road of recovery and adjustment. Rehabilitation programs were developed, particularly by the United States and Britain, to help amputees learn to use prosthetic limbs, return to work, and rebuild their lives. Some men adapted remarkably, others struggled for years. The sheer number of amputees produced by the war, in the hundreds of thousands across all nations, drove major advances in prosthetic design and rehabilitation medicine that continued to develop for decades after the fighting stopped. Fact number 16. The war produced a generation of men who came home with wounds that couldn't be seen. Not physical wounds, but psychological ones. During the Second World War, the condition was often called combat fatigue or battle exhaustion. Today we would recognize much of it as post-traumatic stress disorder. Soldiers who had experienced prolonged combat, witnessed the deaths of friends, survived bombings or prisoner of war camps. Many of them came home carrying something heavy and invisible that didn't go away when the war ended. In the early part of the war, psychological casualties were often not well understood. Some commanders dismissed them. Some men were sent back into battle before they had recovered. But as the war went on, military psychiatrists began to develop better approaches. Rest, safety, and talking with someone trained to listen all helped. The closer to the front that treatment could be given, the better the chances of recovery. By the end of the war, the study of psychological trauma had advanced significantly. It wasn't perfect. Many men returned home without ever receiving the help they needed. But the groundwork had been laid for the recognition of mental health as a genuine and serious part of medical care. Fact number 17. The Red Cross. Both the International Committee of the Red Cross and National Red Cross organizations played a vital supporting role in wartime medical care. The ICRC was based in Geneva, Switzerland, and operated under the rules of the Geneva Conventions, the international agreements that set out how the wounded and prisoners of war were supposed to be treated. Red Cross representatives visited prisoner of war camps to check conditions. Red Cross parcels containing food, medicine, and personal items were sent to prisoners of war in Germany and elsewhere, helping to supplement the often inadequate rations they received. Red Cross nurses served in hospitals across all the Allied nations. In the field, the Red Cross symbol on a medic's helmet or armband was supposed to signal protected status under international law. It didn't always work, particularly in the Pacific, where Japanese forces sometimes targeted medics. But in the European theater, it provided a degree of protection that saved lives. The broader Red Cross network also helped families trace missing relatives, facilitated messages between prisoners and their families, and after the war, assisted in the enormous task of reuniting people who had been separated for years. Fact number 18. One of the most important developments in wartime medicine was the use of sulfonamides, a class of early antibiotic drugs, before penicillin became widely available. Sulfur drugs, as they were commonly known, had been developed in the 1930s and were available at the start of the war. They worked by slowing the growth of bacteria, giving the body's own immune system a chance to fight off infection. Sulfur powder was issued to individual soldiers in small packets as part of their first aid kits. They were instructed to pour the powder directly into a wound as soon as possible after being hit. It was a simple, fast action that could make a significant difference. Sulfur drugs were used to treat wound infections, pneumonia, and other bacterial illnesses. They were not perfect. Some patients had bad reactions to them. But in the years before penicillin was widely available, they were one of the most important tools military medicine had. Many soldiers survived wounds in 1941 and 1942 because of sulfur drugs who might not have survived without them. The development and widespread use of sulfur drugs was a quiet but important chapter in the story of how medicine kept pace with the destructiveness of the war. Fact number 19. Dentistry was not the most dramatic part of wartime medicine, but it mattered more than most people realize. Dental problems, toothaches, infections, broken teeth could render a soldier unable to eat properly, unable to concentrate, and in serious cases genuinely ill from spreading oral infections. Military dentists served in every theater of the war, working in field dental units that were often surprisingly well equipped given the circumstances. In the American military, dental care was considered an essential part of keeping soldiers fit for duty. Recruits had their teeth examined and treated before deployment. Dental units followed troops into the field. In longer campaigns, where soldiers were stationed in one place for weeks or months, dental care became part of the regular health routine. The British, German, Soviet, and Japanese militaries all had dental corps of varying sizes and effectiveness. For men in prisoner of war camps, dental care was often unavailable, and dental problems became a significant source of suffering and health decline over long captivity. The quiet work of military dentists, not dramatic, not heroic in the conventional sense, kept millions of soldiers healthy enough to keep going, day after day through years of war. Fact number 20. Evacuation by air. Flying wounded soldiers out of battle zones and back to hospitals was still a relatively new idea during the Second World War, but it developed rapidly and saved many lives. In earlier wars, the only way to move a wounded man was by stretcher, horse, cart, or eventually ambulance. Aircraft changed that. A plane could cover in an hour a distance that would have taken a ground vehicle a day or more. In the Pacific especially, where the distances between islands were enormous and the terrain made ground transport nearly impossible, air evacuation became essential. American C-47 transport planes were modified to carry stretchers and flew thousands of missions evacuating wounded soldiers. Nurses flew on some of these missions, providing care during the flight. The speed of air evacuation meant that soldiers could reach fully equipped base hospitals far more quickly than before, and that translated directly into better survival rates. By the end of the war, the concept of the medical evacuation aircraft, the medevac, had been firmly established. It would go on to become one of the defining features of military medicine in the conflicts that followed, saving countless lives in Korea, Vietnam, and beyond. Fact number 21. One of the quiet revolutions of wartime medicine was the improvement of anesthesia, the drugs and techniques used to put a patient to sleep or numb pain during surgery. In earlier wars, surgery was often performed with very limited pain control. By the Second World War, things had improved significantly. Ether and chloroform had been used for decades, but they had drawbacks. They were slow to work, hard to control, and sometimes caused dangerous side effects. During the war, sodium pentothal, an intravenous anesthetic, became widely used. It worked quickly, within seconds of injection, and allowed surgeons to begin operating much faster than before. This was important in a field hospital where speed could mean the difference between life and death. Spinal anesthesia was also used for certain procedures, numbing the lower body without putting the patient fully unconscious. Trained anesthetists, doctors and nurses who specialized in managing anesthesia, became essential members of surgical teams. Their work was quiet and largely invisible to anyone watching a surgery from the outside. But without them, the surgeon's skill would have counted for far less. The advances made in anesthesia during the war years carried directly into peacetime medicine and helped make modern surgery far safer than it had ever been before. Fact number 22. The treatment of head injuries and brain wounds was one of the most challenging areas of wartime surgery. The skull and brain are delicate, and wounds to the head, from bullets, shrapnel, or blunt force, required a level of precision and care that was difficult to achieve in field conditions. Neurosurgery, surgery on the brain and nervous system, was still a relatively young specialty in the 1940s, but the war created an enormous need for it and pushed the field forward rapidly. Specially trained neurosurgeons were attached to military hospitals, and techniques for removing bone fragments, relieving pressure on the brain, and cleaning head wounds without causing further damage were refined through hard experience. American neurosurgeon Dr. Loyal Davis and British neurosurgeon Sir Hugh Cairns were among those whose wartime work significantly advanced the field. Cairns also championed the use of crash helmets for military motorcyclists after Lawrence of Arabia, T.E. Lawrence died from a preventable head injury in a peacetime motorcycle accident. Head wound survival rates improved noticeably over the course of the war. Men who would not have survived similar injuries in the First World War lived because of the skills developed under the pressure of the Second. Fact number 23. Chest wounds, injuries to the lungs, heart, and surrounding structures, were among the most immediately life-threatening injuries a soldier could receive. A bullet or fragment that penetrated the chest could collapse a lung, fill the chest cavity with blood, or cause rapid suffocation. In earlier wars, chest wounds were very often fatal. By the Second World War, surgeons had developed better techniques for managing them. A collapsed lung could sometimes be reinflated. Blood pooling in the chest cavity, a condition called hemothorax, could be drained with a tube. Surgeons learned to operate on the chest more confidently, removing shrapnel fragments and repairing damaged tissue. The key was speed. A chest wound left untreated for too long became dramatically harder to manage. This was why the chain of evacuation mattered so much. Getting a chest wound patient to a surgeon within the first hour or two after injury made an enormous difference to his chances. Field medics were trained to recognize the signs of a serious chest wound and to act immediately, sealing open wounds to prevent air from entering, keeping the patient calm and still, and moving him toward care as fast as possible. Every minute, in these cases, truly counted. Fact number 24. Abdominal wounds, injuries to the stomach, intestines, liver, kidneys, and other organs in the belly were another major challenge for wartime surgeons. These wounds were dangerous for several reasons. The organs inside the abdomen are complex and tightly packed. A single fragment of shrapnel could damage multiple structures at once, and the contents of the intestines, if spilled into the abdominal cavity, caused a severe and often fatal infection called peritonitis. Speed was again the critical factor. An abdominal wound patient who reached a surgeon within a few hours had a reasonable chance of survival. One who waited longer faced rapidly worsening odds. Surgeons operating on abdominal wounds had to work methodically but quickly, identifying and repairing each damaged structure, cleaning the cavity, and closing everything up before infection could take hold. The availability of penicillin and sulfur drugs from the mid-war years onward helped reduce post-operative infection rates significantly. Abdominal surgery improved dramatically over the course of the war. Survival rates for abdominal wounds rose from figures that had been considered acceptable in the First World War to levels that would have seemed extraordinary just a decade before. Much of what modern abdominal surgeons know traces its roots back to this difficult, urgent work. Fact number 25. The treatment of fractures, broken bones, was a constant part of wartime medical work. Combat fractures were often more complicated than the kind caused by accidents in peacetime. A bullet or shrapnel fragment passing through a limb didn't just break a bone cleanly. It often shattered it, driving fragments of bone outward and damaging surrounding muscle and tissue at the same time. These were called compound fractures, and they were much harder to treat. Military surgeons used plaster casts, metal pins, and traction devices to stabilize fractured limbs. The Thomas splint, a simple metal frame developed during the First World War, was still widely used for femur fractures, the large thigh bone, which if left unstabilized could cause fatal blood loss. Applying a Thomas splint correctly in the field, quickly and firmly, became a basic skill for combat medics. Bone infections were a serious risk with open fractures, and the arrival of sulfur drugs and penicillin helped address this. For men who suffered complex fractures, recovery was often long, months in hospital, followed by weeks of rehabilitation. Many came home with limbs that were slightly shorter, or that never quite moved the same way again, but they came home, which in the brutal arithmetic of wartime medicine was what mattered most. Fact number 26. Psychiatric care for soldiers was one of the areas where the Second World War brought the most significant changes in thinking. Before the war, mental breakdown under combat stress was not well understood and was often stigmatized. Soldiers who collapsed psychologically were sometimes seen as weak or cowardly. The First World War had introduced the concept of shell shock, but even that was viewed with suspicion by many military commanders. By the Second World War, military psychiatrists were making the case, loudly and persistently, that combat stress was a medical reality, not a personal failing. They argued that any soldier, given enough exposure to combat, could break down. It was not a question of character, it was a question of limits. Rest, safety, food, and simple human conversation could help many men recover. The closer to the front the treatment was given, and the sooner after breakdown, the better the results. Psychiatrists developed what became known as the PIE principle: proximity, immediacy, expectancy. Treat the soldier close to the front, immediately, and with the expectation that he would recover and return to duty. It worked for many men, not for all. But the shift in understanding, from weakness to wound, was one of the most important mental shifts in military medicine during the entire conflict. Fact number 27. Venereal diseases, infections spread through sexual contact, were a significant medical problem for all armies during the war. Though they were rarely discussed publicly, millions of young men far from home, stationed in foreign countries for months or years at a time, were inevitably exposed to sexually transmitted infections. Gonorrhea and syphilis were the most common. Before the war, syphilis in particular had been difficult to treat and could cause serious long-term health damage. During the war, penicillin proved remarkably effective against both gonorrhea and syphilis, and this became one of its earliest and most widely used applications in military medicine. Military health authorities also ran extensive, if awkward, education campaigns, distributing prophylactic kits and encouraging soldiers to seek treatment without fear of punishment. The American military was particularly systematic about this. Cases were tracked, treatment was provided, and the goal was to keep men healthy and able to serve rather than to punish them for behavior that was understood to be essentially inevitable. The rates of long-term disability from venereal disease among Second World War veterans were significantly lower than those of the First World War, largely because of penicillin and because of the more pragmatic attitude taken toward prevention and treatment. Fact number 28. The care of wounded soldiers did not end when the surgery was over. Recovery, what today we would call post-operative care and rehabilitation, was a long and important part of the medical process. In base hospitals and convalescent facilities, nurses and orderlies cared for men through days, weeks, and sometimes months of recovery. Wounds needed to be cleaned and redressed regularly. Patients needed to be helped to eat, to move, to slowly regain strength. Physical therapy, exercises to rebuild muscle and restore movement, was used increasingly as the war went on. For men who had lost limbs, learning to use a prosthesis was a long process that required patience and skilled guidance. Occupational therapy, activities designed to help patients maintain mental health and practical skills during long recovery periods, was also developed and expanded during the war years. Red Cross volunteers visited hospitals, bringing books, games, and company. In some facilities, men who were recovering were taught new skills, woodworking, drawing, bookkeeping, to prepare them for life after the military. All of this was not glamorous work. It was slow and patient and repetitive, but it was medicine too, the quiet, steady kind, and the men who benefited from it carried its effects for the rest of their lives. Fact number 29. In the deserts of North Africa, wartime medicine faced a unique set of challenges. The environment itself was a medical problem. Extreme heat caused dehydration, heat exhaustion, and heat stroke. Sand got into wounds and made infection more likely. Clean water was scarce, which affected everything from wound cleaning to basic hygiene. Flies were everywhere and spread disease. The armies fighting in North Africa, British, American, German, Italian, Australian, and others, all had to adapt their medical practices to conditions very different from what they had trained for. Dehydration was a constant concern, and medics were instructed to ensure that wounded soldiers received water as early as possible. Sunburn and eye damage from intense reflected light were common non-combat medical complaints. Dysentery, a severe intestinal illness caused by contaminated food and water, swept through units regularly and could take large numbers of men out of action at once. The desert also played tricks with supply lines, making it hard to keep medical units stocked with the equipment and drugs they needed. Medical officers who served in North Africa developed a practical resourcefulness, learning to do more with less, to improvise, and to prioritize ruthlessly, that served them well when the fighting eventually moved on to Italy and beyond. Fact number 30. Italy proved to be one of the most grueling campaigns for Allied medical services. After the invasion of Sicily in July 1943 and the subsequent push up the Italian peninsula, Allied forces faced a slow, bloody advance through mountainous terrain in often terrible weather. The mountains of central Italy, the Apennines, were cold, wet, and difficult to move through. Casualties had to be carried down steep hillsides by stretcher bearers before they could reach vehicles. In winter, the cold added hypothermia and frostbite to the list of medical problems. The fighting at Monte Cassino in early 1944 was particularly brutal. Medical units operated as close to the front as possible, but the terrain made evacuation agonizingly slow. Mule teams were used to carry supplies up to forward positions and carry wounded men back down, one of the more unusual images of a modern war. Surgeons in Italy became skilled at treating wounds under very challenging conditions. The Italian campaign lasted until the end of the war in Europe in May 1945, and throughout those 2 years the medical services worked continuously, treating combat casualties, illness, cold injuries, and the many complications that arose from fighting in difficult terrain for a long time. Fact number 31. Among the many medical challenges of the Second World War, the treatment of eye injuries deserves its own mention. Modern warfare, with its explosions, shrapnel, burning vehicles, chemical agents, and intense flashes of light, produced eye injuries at a rate that peacetime medicine rarely encountered. Fragments of metal or debris could penetrate the eye, burns could damage the eyelids and cornea. The blast pressure from nearby explosions could cause internal eye injuries with no visible external wound. Military ophthalmologists, eye specialists, worked in base hospitals treating men whose vision had been damaged or lost. Microsurgical techniques for removing foreign bodies from the eye were refined during the war. Corneal transplantation was still very limited at this time, so when the cornea, the clear front surface of the eye, was badly damaged, the options were limited. Men who lost their sight faced a particularly difficult adjustment. Dedicated rehabilitation programs were developed, perhaps the most famous being the one run by Dr. Richard Doherty in the United States, to help blinded veterans learn to navigate daily life, find employment, and maintain independence. The loss of sight was one of the most life-altering injuries the war produced, and the people who helped those men rebuild their lives showed a kind of compassion that is quietly remarkable. Fact number 32. The liberation of Nazi concentration camps in 1945 presented military medical teams with a situation almost entirely outside their training or experience. When Allied soldiers entered camps like Bergen-Belsen, Dachau, and Buchenwald, they found thousands of survivors in states of extreme starvation, disease, and physical deterioration. The medical teams that accompanied the liberating forces were overwhelmed. The survivors, many of them barely alive, were suffering from conditions that required urgent and careful treatment. Typhus was rampant, tuberculosis was widespread, malnutrition had left bodies so depleted that feeding people too quickly could actually kill them, a condition known as refeeding syndrome. Medical officers had to learn rapidly how to provide nutrition carefully and slowly to people whose digestive systems had shut down. Treating typhus required delousing, removing the lice that spread the disease on a massive scale. Field hospitals were set up near the camps. The British Army at Bergen-Belsen, which held perhaps the worst conditions of any liberated camp, deployed hundreds of medical personnel. Approximately 14,000 survivors died even after liberation, simply because they were too far gone to recover. The experience of liberating and treating concentration camp survivors left deep marks on every medical person who was there. Fact number 33. One area of wartime medicine that developed very rapidly was the treatment of burns, particularly in the context of naval warfare. When a ship was hit by a torpedo, a bomb, or shell fire, fires broke out quickly, and sailors caught in those fires suffered severe burns to their hands, faces, and arms. Naval surgeons and medics developed specific protocols for managing burns at sea, where resources were limited and the journey to a proper hospital could take days. Burn patients lost enormous amounts of fluid through their damaged skin, so fluid replacement, giving the patient large amounts of intravenous fluids, was essential. Keeping burns clean and covered to prevent infection was critical. In many cases, the initial care given on board ship in the hours after the injury determined whether the patient survived long enough to reach specialist treatment ashore. The tanker and destroyer crews of all nations faced this risk constantly. The development of better burn treatment protocols during the war, driven by the sheer number of burn casualties produced by naval combat, fed directly into the improvements in civilian burn medicine that followed in the post-war decades. Fact number 34. Frostbite and cold injuries were significant medical problems on the Eastern Front and in other cold weather theaters such as Norway, the Aleutian Islands, and the mountains of Italy and Yugoslavia. When body tissue freezes, which happens when exposed to temperatures below zero for extended periods, especially combined with wind and wet, the damage can be severe and permanent. Fingers, toes, ears, and noses were the most commonly affected. Mild frostbite, sometimes called frostnip, could be treated with gentle rewarming. Severe frostbite caused tissue death that could require amputation. On the Eastern Front, frostbite casualties during the winter of 1941 to 1942 were catastrophic, particularly for the German army, which had not been equipped or prepared for the Russian winter. German soldiers wrapped their feet in newspaper and straw. Some units lost more men to cold injuries than to enemy action during that first terrible winter. The Soviet army was better prepared, having experience with cold weather warfare, but still suffered significant cold injury casualties. Medical officers learned that the key was prevention, proper clothing, regular rotation of soldiers out of exposed positions, and vigilance about checking men for early signs of cold injury before it became serious. Fact number 35. The role of pharmacists and medical supply chains in wartime medicine is rarely celebrated, but it was absolutely essential. Without a reliable flow of drugs, bandages, surgical instruments, anesthetics, plasma, and other supplies, even the best trained surgeon could do very little. Military medical supply chains stretched from factories in the United States and Britain all the way to field hospitals a few miles from the front lines. Pharmacists in base hospitals mixed and dispensed medications. Supply officers tracked inventories and placed orders. Ships carried medical supplies across oceans. Trucks moved them to forward areas. And at every step, the risk of disruption by enemy action, by weather, by simple logistical failure was real. When supplies ran short, medical officers improvised. They stretched limited stocks of penicillin by using it only for the most critical cases. They reused bandages after sterilization. They adapted procedures to use whatever was available. The men who managed these supply chains, often working in anonymity, far from the drama of combat, made it possible for everything else to function. Their work was invisible in the way that all logistics is invisible, noticed only when it fails, taken for granted when it succeeds. Fact number 36. The experience of being a prisoner of war had severe medical consequences for many men. Prisoners of war held by Germany in camps that followed the Geneva Conventions, particularly Western Allied officers, were in a very different situation from those held in Japanese camps or from Soviet prisoners held by Germany. In Japanese camps, the death rate among Western Allied prisoners of war was approximately 27%, compared to about 4% in German camps holding Western Allied prisoners. Japanese captors often provided minimal food, little or no medical care, and subjected prisoners to brutal physical treatment. Diseases including cholera, dysentery, malaria, and beriberi, a disease caused by thiamine deficiency, spread through camps where sanitation was poor and nutrition was almost non-existent. Prisoner of war doctors, captured medical officers who were allowed to treat their fellow prisoners, did extraordinary work under impossible conditions. They improvised medicines from available materials, performed surgery with inadequate instruments, and maintained records of their patients with a professionalism that was remarkable given the circumstances. When the camps were liberated in 1945, many survivors were in critical condition and required intensive medical care for weeks or months before they could safely travel home. Fact number 37. Military medicine in the Second World War also had to grapple with the psychological effects of captivity. Men held as prisoners of war for months or years underwent a kind of slow psychological erosion that was distinct from the acute combat stress experienced by frontline soldiers. The monotony, the uncertainty, the powerlessness, the hunger, and the sometimes random cruelty of captors combined to produce depression, anxiety, and what some doctors at the time described as a kind of emotional numbness. Some men adapted by creating structure, organizing educational programs, theatrical productions, sports competitions, and religious services within the camps. These activities were not just entertainment, they were medicine of a different kind. maintaining mental health, preserving identity, and giving men a reason to keep going. When prisoners of war were liberated, many struggled to readjust to ordinary life. Some found it difficult to eat normally, sleep safely, or trust the people around them. Post-war studies of former prisoners of war, particularly those held in Japanese camps, found elevated rates of anxiety, depression, and physical illness that persisted for decades. The long shadow of captivity was one of the quieter medical legacies of the war, and it shaped the way that military psychiatry approached the treatment of returning prisoners for a generation. Fact number 38. Tropical diseases beyond malaria were a constant medical burden in the Pacific and in Southeast Asian theaters of war. Scrub typhus, spread by the bites of infected mites in jungle undergrowth, caused high fevers, headaches, and sometimes fatal organ failure. It was particularly prevalent in Burma, New Guinea, and the Philippines. Dengue fever, also spread by mosquitoes, caused intense joint and muscle pain, earning it the nickname breakbone fever, and while rarely fatal, it could leave a soldier too weak to function for weeks. Filariasis, spread by mosquitoes, caused long-term damage to the lymphatic system. Hookworm, amoebic dysentery, and various fungal infections all took their toll on men living in wet, warm conditions with limited sanitation. Military preventive medicine, the branch of medicine focused on stopping disease before it started, worked hard in these environments. Insect repellent was developed and distributed. Clothing was treated with insecticide. Water purification tablets became standard issue. Malaria suppression programs used DDT, not yet understood to have environmental costs, to reduce mosquito populations near camps. For every soldier who was wounded in the Pacific, there were many more who were laid low by disease, and the medical effort to control those diseases was as important as anything happening in the operating tent. Fact number 39. The contribution of medical research conducted during the war, both in the laboratory and in clinical practice, had lasting effects that extended far beyond the conflict itself. The urgent need to treat wounds, prevent infection, manage blood loss, and handle mass casualties drove innovation at a pace that peacetime medicine rarely achieved. Penicillin production was industrialized. Blood banking was developed and refined. New surgical techniques were tested and perfected. Plastic and reconstructive surgery advanced enormously. The understanding of shock, the dangerous collapse of the circulatory system that could follow severe injury or blood loss, was deepened significantly. Burn treatment improved. Psychiatric understanding of trauma developed. All of this knowledge came home with the doctors, nurses, and medics who had gathered it in the hardest possible school. In the years after the war, medical schools updated their curricula. Hospitals adopted new techniques. Patients who would have died in 1939 from infections, from blood loss, from burns, survived in 1950 because of what had been learned between those years. The war's medical legacy was one of the stranger, quieter gifts hidden inside its enormous destruction. Knowledge paid for at terrible cost, but knowledge that went on saving lives for generations. Fact number 40. One of the most enduring images of wartime medical care is the military nurse. Working long shifts, moving calmly between beds in a ward that might be a tent or a converted school or a hospital ship rolling on a dark sea. The nurses of the Second World War came from many countries and served in many roles. American nurses flew on evacuation aircraft and waded ashore at Anzio. British nurses served in the Western Desert and in field hospitals from Normandy to Germany. Australian nurses survived the sinking of the Viner Brook in 1942, swam to shore, and were then captured by Japanese forces. Some were killed, others survived years of brutal captivity. Soviet women served as frontline medics and snipers as well as nurses. All of them shared something essential, a commitment to the patient in front of them, whoever that patient was, whatever the conditions around them. Nursing in wartime was physically exhausting, emotionally demanding, and sometimes genuinely dangerous, and yet the accounts left behind by nurses who served are often characterized not by complaint, but by a quiet pride in the work, in the men they helped, in the lives they touched, and in the knowledge that what they did mattered. Every single day, in the most direct and human way imaginable. Fact number 41. One of the most significant medical advances to come directly out of the Second World War was the development of modern blood banking. Before the war, blood transfusions existed, but were complicated and risky. Blood had to be taken from a donor and given to a patient almost immediately. There was no reliable way to store it. During the war, scientists and doctors worked urgently to solve this problem. They discovered that blood mixed with sodium citrate could be stored for up to 3 weeks under refrigeration. Collection centers were set up across the United States and Britain, where millions of civilians donated blood voluntarily. The blood was typed, tested, stored, and shipped forward to hospitals near the front lines. In the United States alone, the Red Cross collected approximately 13 million units of blood during the war. The system that was built to support this effort, the collection centers, the storage protocols, the distribution networks, became the foundation of the modern blood banking system that hospitals around the world still use today. Every time a patient receives a blood transfusion in a modern hospital, the system that makes it possible traces its origins directly back to the urgent medical problem-solving of the Second World War. It is one of the most direct and tangible legacies that the war left behind. Fact number 42. The treatment of spinal cord injuries was one of the areas where wartime medicine made quiet but lasting progress. A wound to the spine, from a bullet, shrapnel, or blunt trauma, could cause partial or complete paralysis of the body below the injury. Before the Second World War, the outlook for men with spinal cord injuries was very poor. Most died within months, usually from urinary tract infections or pressure sores, both of which were complications of being unable to move. A British doctor named Ludwig Guterman changed this. Working at Stoke Mandeville Hospital in England, he developed a comprehensive approach to treating spinal cord injury patients that emphasized careful nursing, regular turning of patients to prevent pressure sores, rigorous management of bladder and bowel function, and crucially, rehabilitation. He believed that men with spinal cord injuries could live full and active lives if given the right care. He introduced sport as part of rehabilitation, eventually organizing competitions between wheelchair users that would later become the foundation of the Paralympic Games. Guterman's work saved the lives of many men who would previously have died, and gave them back a quality of life that earlier medicine had not thought possible. His legacy extends from the battlefields of the 1940s to every Paralympic stadium in the world today. Fact number 43. Mobile surgical units, small, self-contained teams of surgeons, nurses, and medical staff who could travel quickly and set up operating facilities almost anywhere, were one of the most effective innovations of wartime medicine. Before the war, major surgery required a fixed, well-equipped hospital. The war made that impossible near the front lines, so the hospital, in a sense, came to the patient. Mobile surgical units carried everything they needed in trucks or on pack animals: surgical instruments, anesthetics, sterilization equipment, basic medicines, and portable lighting. They could be operational within hours of arriving at a new location. In North Africa, they moved with the fast-shifting front lines across hundreds of kilometers of desert. In the Pacific, they were airlifted onto newly captured islands. In Europe, they followed the advancing Allied armies through France, Belgium, and into Germany. Soviet mobile surgical units served on the enormous Eastern Front, moving constantly. The concept proved so effective that it never went away. The mobile surgical hospital, refined and improved, became the MASH unit of the Korean War and the forward surgical team of modern military medicine. The idea that surgery should come to the wounded soldier, rather than waiting for the wounded soldier to come to surgery, was one of the defining principles of wartime medical thinking. Fact number 44. The experience of the Normandy landings on June 6, 1944, D-Day, placed extraordinary demands on Allied medical services. In the planning stages, medical officers had calculated expected casualty rates and prepared accordingly, but the reality of the landings, particularly at Omaha Beach, where American forces suffered very heavy casualties in the first hours, overwhelmed initial preparations. Medics landed with the first waves of soldiers, treating the wounded under fire on the beach itself. Many medics were killed. The wounded lay in the surf and on the sand for hours before they could be evacuated. Offshore, the designated hospital ships filled rapidly. Landing craft returning to the ships carried wounded men back across the channel. Within the first 24 hours, thousands of casualties had been treated. In the days and weeks that followed, as the Allied forces pushed inland, field hospitals were established just behind the advancing front. The scale and speed of the medical operation at Normandy was remarkable, a testament to the months of planning and training that had gone into it. The lessons learned at Normandy about mass casualty management were applied immediately and continued to inform military medical planning for decades afterward. Fact number 45. The management of pain in wounded soldiers was a constant challenge that military medicine addressed with the tools available at the time. Morphine was the primary painkiller used in the field. It was carried by combat medics in small syrettes, a kind of preloaded injector that could be administered quickly and easily, even in difficult conditions. Morphine was effective at reducing pain and calming distressed patients, but it had to be used carefully. Too much could dangerously suppress breathing. This was why medics marked a patient's forehead with the letter M after giving morphine, so that the next medical person who treated him would know a dose had already been given and would not accidentally administer a second one. Aspirin was used for milder pain. Sodium pentothal, given intravenously, provided rapid sedation before surgery. Ether and chloroform were used as inhalation anesthetics during operations. Spinal blocks numbed the lower body for certain procedures. None of these tools were perfect. Men woke from surgery in significant pain. Long recovery periods in hospital could be deeply uncomfortable. But the availability of reliable pain control, particularly morphine in the field, made a real difference to the experience of being wounded, and the soldiers who received it in their worst moments were grateful for the quiet mercy it provided. Fact number 46. The war in the Pacific created unique challenges for the treatment of jungle wounds. In the dense tropical forests of New Guinea, the Philippines, Burma, and the Solomon Islands, wounds became infected with a speed and severity that was unlike anything seen in other theaters. The combination of heat, humidity, soil rich with bacteria, and the difficulty of keeping wounds clean in jungle conditions meant that even minor injuries could rapidly become serious. A scratch from jungle undergrowth could become badly infected within 24 hours. Cuts from coral, common in the Pacific Island landings, were particularly prone to infection because coral harbored aggressive bacteria. Fungal infections of the skin, feet, and ears were endemic. Jungle rot, a general term for the various skin infections that afflicted soldiers in tropical environments, could render men unable to walk or use their hands. Medical officers in the Pacific developed specific protocols for jungle wound care: aggressive cleaning, liberal use of sulfur powder, careful bandaging to exclude insects and moisture, and rapid evacuation of anyone whose wound showed early signs of infection. The lessons learned about infection in tropical environments during the Second World War contributed directly to the understanding of wound care that informed medicine in subsequent conflicts in Asia and elsewhere. Fact number 47. Reconstructive surgery, rebuilding faces and bodies damaged by injury, advanced enormously during the Second World War. The war produced thousands of men with severe facial injuries, lost jaws, destroyed noses, burned and scarred skin, damaged eye sockets. Before the war, reconstructive surgery existed but was limited. The scale of need created by the war drove rapid innovation. Archibald Mackindo in Britain, working primarily with burned Royal Air Force pilots, developed new skin grafting techniques and understood that reconstruction was not just about appearance. It was about giving men back the ability to live normally, to eat, to speak, to smile. Harold Gillies, who had pioneered reconstructive surgery in the First World War, continued his work in the Second. In the United States, surgeons including Varistad Kazanjian developed techniques for reconstructing jaws and facial bones. These surgeons worked in close collaboration with dentists, who helped reconstruct the dental structures that gave faces their shape. The results were not always perfect. The technology of the time had limits, but men who might have spent the rest of their lives hidden from the world because of their injuries were instead given faces they could live with. The advances made in this period shaped the entire field of plastic and reconstructive surgery for the rest of the 20th century. Fact number 48. The war produced an enormous number of amputees, and this drove rapid development in the design and manufacture of prosthetic limbs. Before the war, prosthetics were relatively crude, heavy wooden or leather devices that provided basic function but were uncomfortable and limited. The tens of thousands of men who lost limbs during the war created both the need and the funding for much better solutions. In the United States, a major research program was launched to develop improved prosthetics. Engineers and doctors worked together, an unusual collaboration at the time, to design lighter, more functional artificial limbs. New materials were tested. Better attachment systems were developed. The concept of the prosthetic being fitted carefully to the individual patient, rather than being a standard device handed out to everyone, became standard practice. Rehabilitation programs trained amputees to use their new limbs effectively. Physical therapists worked with patients for months. Many men achieved levels of function that surprised even their doctors, returning to physical work, to sport, and to active lives. The prosthetics industry that emerged from the Second World War was far more sophisticated than the one that had existed before it, and the research and manufacturing infrastructure built during the war continued to benefit amputees, both military and civilian, for decades afterward. Fact number 49. The medical care provided to civilian populations during the war deserves recognition alongside the care given to soldiers. In bombed cities across Europe and Asia, civilian hospitals were overwhelmed, damaged, or destroyed. Doctors and nurses treated blast injuries, burns, crush injuries from collapsing buildings, and the psychological shock of bombardment. In Britain during the Blitz, the National Health Service did not yet formally exist, but a system of emergency medical service hospitals, set up in anticipation of war casualties, handled hundreds of thousands of civilian casualties. In Germany, civilian hospitals continued to function even as Allied bombing intensified, until the very end of the war made normal medical practice almost impossible. In the Soviet Union, hospitals were evacuated eastward ahead of the German advance. In occupied countries, civilian doctors continued their work under occupation, sometimes at great personal risk, treating resistance fighters, hiding Jewish patients, and refusing to collaborate with policies that violated their medical ethics. The civilian medical experience of the Second World War was as varied and as demanding as the military one, and the doctors, nurses, and paramedics who maintained care for ordinary people through years of destruction and chaos showed a quiet, steady heroism that is easy to overlook but impossible to overstate. Fact number 50. One of the lesser-known aspects of wartime medical care was the role played by medical personnel who were themselves prisoners of war. When a military unit was captured, its medical officers were often retained by the capturing force. Under the Geneva Conventions, medical personnel were protected and were supposed to be allowed to continue caring for sick and wounded prisoners. In practice, this varied enormously. In German camps holding Western Allied prisoners, captured medical officers were generally allowed to function, though with limited supplies. They maintained sick bays, treated illnesses and injuries, kept medical records, and provided a degree of organized healthcare within the camp. In Japanese camps, captured Allied medical officers faced far more difficult conditions, limited supplies, hostile guards, sick and dying patients, but continued to work regardless. Some of these prisoner doctors became extraordinary figures. They improvised medicines, performed surgery with inadequate instruments, and maintained a standard of professional care that was, in the circumstances, almost unbelievable. Their patients, fellow prisoners who survived because of their work, spoke of them afterward with a reverence that went beyond ordinary gratitude. These prisoner doctors had given everything they had, in the worst possible conditions, for the men in their care. Their stories are among the quietest and most profound in the entire history of wartime medicine. Fact number 51. Nutrition and diet were medical concerns that the war brought sharply into focus. In sieges, in prisoner of war camps, in occupied territories, and in the global disruption of food supply chains, millions of people experienced severe malnutrition. Military doctors had to understand and treat conditions caused by nutritional deficiency that peacetime medicine rarely encountered at scale. Scurvy, caused by lack of vitamin C, appeared in isolated garrisons and among prisoners. Beriberi, caused by lack of thiamine or vitamin B1, was common in Japanese prisoner of war camps where polished white rice was the main food. Pellagra, caused by lack of niacin, appeared in some prisoner populations. Night blindness caused by vitamin A deficiency affected soldiers in campaigns where fresh food was unavailable for months. Military nutritionists worked to design rations that provided adequate nutrition within the constraints of what could be packaged, transported, and prepared in field conditions. The American K ration and C ration, the British composite ration, all were the result of careful nutritional calculation. Vitamins were added to some field rations as the understanding of deficiency diseases improved. The war, in its terrible way, became an accelerated course in nutritional science, and the understanding gained during those years fed directly into the development of modern dietary guidelines and food fortification programs. Fact number 52. The liberation of the Philippines in 1944 and 1945 brought American military medical teams face to face with the survivors of Japanese captivity. Men who had endured years in brutal conditions, the survivors of the Bataan Death March of 1942 and the subsequent years of captivity in camps across the Philippines, Japan, and other parts of the Japanese Empire were, by the time of liberation, in desperate physical condition. Severe malnutrition, untreated infections, tropical diseases, and the physical damage of beatings and forced labor had left many men profoundly weakened. American medical teams worked quickly to provide emergency nutrition, treat infections with the penicillin and sulfur drugs now available in abundance, and address the most pressing physical problems. But the psychological damage was often deeper and harder to treat than the physical. Men who had survived years of captivity by suppressing their emotions and focusing purely on survival sometimes found that the return to safety and plenty was disorienting and even distressing. The psychological complexity of liberation, the mixture of relief, grief, disbelief, and numbness, was something that military psychiatrists were only beginning to understand. The care given to returning prisoners of war in the final months of the war and in the years that followed was an important early chapter in the understanding of long-term trauma and its treatment. Fact number 53. Gas warfare, the use of chemical weapons, had been devastating in the First World War, and both sides in the Second World War feared its use. Extensive preparations were made by all major armies to treat potential gas casualties. Soldiers were trained in the use of gas masks. Medical officers were trained to recognize and treat the effects of mustard gas, phosgene, chlorine, and other chemical agents. Decontamination procedures were developed and drilled. Stockpiles of antidotes and treatment supplies were maintained. In the event, large-scale chemical warfare did not occur between the major powers during the Second World War. A combination of deterrence, fear of retaliation, and logistical difficulty kept it from being used on the main battlefields. However, there were significant incidents. In December 1943, a German bombing attack on Allied ships in the Italian port of Bari hit an American vessel secretly carrying mustard gas bombs, releasing the gas and causing hundreds of casualties, a fact kept secret for years. Japan used chemical weapons in China. Italian forces had used gas in Ethiopia before the war. Medical officers who had to treat actual gas casualties found that their preparations, while imperfect, gave them a foundation to work from in situations for which there was no good textbook. Fact number 54. The atomic bombings of Hiroshima on August 6, 1945, and Nagasaki on August 9, 1945, created medical emergencies unlike anything in history. The immediate explosions killed enormous numbers of people. Estimates for Hiroshima range from 70,000 to 80,000 dead immediately, with total deaths by the end of 1945 estimated at 90,000 to 166,000. Nagasaki saw 40,000 immediate deaths with a similar toll over following months. Beyond the blast and fire casualties, survivors faced the effects of radiation exposure, a medical phenomenon that was not yet well understood. In the days and weeks after the bombings, doctors treating survivors noticed patterns of illness, hair loss, severe bleeding, weakened immunity, and death that were unlike ordinary burn or blast injuries. This was radiation sickness, caused by exposure to the intense radiation produced by the nuclear explosions. Japanese and later American medical teams studied the survivors, the hibakusha, and the data gathered from this terrible natural experiment became the foundation of the medical understanding of radiation injury. The ethical dimensions of how this knowledge was gathered, and how the survivors were treated in subsequent decades, remain complex and deeply sensitive. But the medical reality of nuclear weapons, the injuries they cause and the care they require, was first confronted on those 2 mornings in August 1945. Fact number 55. The role of chaplains in wartime medical care is sometimes overlooked, but it was considered genuinely important by the military medical establishment. Chaplains, religious ministers who served alongside military units, spent a great deal of their time in hospitals, aid stations, and field medical units. They sat with dying men. They wrote letters to families. They prayed with the wounded. They listened to men who needed to talk, but not necessarily about anything a doctor could treat. In the understanding of the time, and in much subsequent research, the presence of spiritual and emotional support alongside physical medical care made a real difference to patients' well-being and recovery. Men who had a sense of meaning, of being cared for as a whole person rather than just as a body to be repaired, often recovered better than those who were treated in a purely clinical way. Chaplains also helped maintain morale in medical units themselves. Among the doctors and nurses who worked under enormous stress for months and years, and who needed their own form of support, the integration of spiritual care into the wartime medical system was not universal, and its effectiveness was not systematically measured. But the thousands of accounts left by soldiers who valued the presence of a chaplain in their worst moments speak clearly enough. Fact number 56. The war accelerated the development of radiology, the use of X-rays to see inside the body, as a tool in military medicine. X-ray machines had existed since the late 19th century, but they were large, fragile, and difficult to transport. By the Second World War, more portable X-ray units had been developed that could be used closer to the front lines. X-rays allowed surgeons to locate shrapnel and bullet fragments inside the body, information that was critical for planning surgery. They could reveal broken bones, collapsed lungs, and foreign objects in the digestive tract. In base hospitals, full X-ray departments operated around the clock during busy periods. The radiographers who operated the machines, many of them women in Allied countries, worked long shifts reading films and helping surgeons plan operations. The experience gained by radiologists during the war, the sheer volume of traumatic injuries they examined and reported on, significantly advanced the specialty. Patterns of injury from different types of weapons were documented. The relationship between what the X-ray showed and what the surgeon found in the operating room was studied and recorded. All of this knowledge fed back into both military and civilian radiology, improving the quality of diagnosis and the planning of surgery for decades after the war ended. Fact number 57. The care of soldiers suffering from shell shock, what we now understand as combat-related post-traumatic stress, evolved significantly between the beginning and the end of the war. At the outset, military attitudes towards psychological breakdown were mixed. Some commanders were sympathetic and understood it as a medical reality. Others viewed it with suspicion or contempt. Psychiatrists serving in military hospitals pushed consistently for a more humane and scientifically grounded approach. They argued, based on clinical observation, that the factors predicting psychological breakdown were largely situational, related to the duration and intensity of combat, to sleep deprivation, to witnessing death, to moral injury, rather than to personal weakness or lack of courage. Treatment methods that developed during the war included narcosynthesis, the use of drugs to help patients access and process traumatic memories, as well as group therapy, rest, and gradual return to normal activities. Not all of these methods would be considered appropriate today, but they represented a genuine attempt to understand and treat a condition that had been poorly served by medicine in the past. The groundwork laid during the Second World War in the understanding of combat trauma became, in the decades that followed, the foundation for the recognition and treatment of post-traumatic stress disorder as a diagnosable and treatable medical condition. Fact number 58. The medical history of the Second World War cannot be told without acknowledging the crimes committed in the name of medicine by Nazi doctors and by certain Japanese military medical units. Nazi physicians conducted experiments on concentration camp prisoners, exposing them to extreme cold, to infectious diseases, to pressure changes, to surgical procedures performed without consent or anesthesia. The results of these experiments were obtained through torture and murder. After the war, the Nuremberg doctors' trial in 1946 and 1947 prosecuted 23 defendants, physicians and others, for war crimes and crimes against humanity. 16 were convicted, 7 were executed. The trial produced the Nuremberg Code, a set of principles establishing that voluntary informed consent is absolutely essential in any medical experiment involving human subjects. This code became the foundation of modern medical ethics and research ethics. Japan's Unit 731 conducted similarly horrific experiments on prisoners in China, experimenting with biological weapons and conducting vivisections. These crimes were among the most profound betrayals of medical ethics in history. The Nuremberg Code that emerged from their prosecution continues to govern the ethics of medical research around the world today, a permanent reminder of what medicine must never become. Fact number 59. The end of the war in Europe in May 1945 and in the Pacific in September 1945 did not mean the end of the medical work that the war had created. Millions of wounded men were still in hospitals. Millions of displaced persons needed medical attention. Concentration camp survivors required ongoing care. Prisoners of war returning from captivity needed comprehensive medical assessment and treatment. The newly formed United Nations Relief and Rehabilitation Administration, UNRA, deployed medical teams across Europe and Asia to address the enormous public health needs of the post-war world. Typhus, tuberculosis, and other infectious diseases threatened populations weakened by years of malnutrition and disruption. Vaccination campaigns were organized. Hospitals that had been damaged or destroyed were rebuilt. Medical supply chains were redirected from supporting armies to supporting civilian populations. The transition from wartime to peacetime medicine was not instant or easy. It took years, but the infrastructure, the knowledge, and the trained personnel that the war had produced were turned, gradually and persistently, toward healing the wounds that the war had left behind, in bodies, in minds, and in communities that had been broken and were slowly, quietly beginning to rebuild. Fact number 60. The legacy of Second World War medicine extended far beyond the immediate post-war period and shaped the practice of medicine for the rest of the 20th century. Penicillin and the broader antibiotic era it inaugurated transformed the treatment of infectious disease. Blood banking made modern surgery possible. Advances in anesthesia made operations safer. Reconstructive surgery gave new lives to people with severe injuries. The understanding of nutritional deficiencies improved public health. Psychiatric insights into trauma changed the way mental illness was understood and treated. Rehabilitation medicine became a recognized and important specialty. The lessons of triage and mass casualty management were built into emergency medicine training worldwide. The Nuremberg Code reformed medical ethics globally. The prosthetics industry was transformed. The medevac concept revolutionized emergency transport. None of these things came without cost. They were learned in the hardest school imaginable, on battlefields and in prison camps and in the ruins of bombed cities, by men and women working in impossible conditions with whatever tools they had. But the knowledge they gathered, the techniques they developed, and the principles they established became gifts, painful, hard-won gifts, that went on saving lives long after the guns fell silent and the world began, slowly and imperfectly, to find its way back to peace. Fact number 61. One of the quietest and most enduring stories of wartime medicine is the story of the medics, doctors, nurses, and support staff who came home after the war and simply went back to work. They returned to civilian hospitals, to country practices, to university teaching positions, and to research laboratories. Many of them never spoke much about what they had seen or done during the war. They folded their experiences quietly into the fabric of their peacetime lives and got on with the business of caring for people. But what they carried with them, the skills they had developed, the things they had learned, the ways their thinking had been permanently changed by years of working under pressure, went with them into every consultation room, every operating theater, every lecture hall where they stood in front of a new generation of medical students. The young doctors they trained had teachers who had seen things that no textbook could fully describe. The surgical techniques that became standard in peacetime hospitals had often been refined in field tents by surgeons who had performed the same operation hundreds of times under fire. The careful, quiet transmission of that knowledge, from those who had been there to those who had not, was one of the most important medical inheritances of the war. It happened without ceremony, in ordinary workplaces, across ordinary days, for decades after the fighting stopped. Fact number 62. And so we come to the end of this quiet journey through the medical history of the Second World War. It is a history that belongs to many kinds of people. To the surgeons who operated through the night in canvas tents while artillery rumbled in the distance. To the nurses who held the hands of frightened men far from home. To the medics who ran toward the wounded instead of away from them. To the researchers who stayed up late in laboratories trying to produce enough penicillin for the next landing. To the prisoner doctors who kept working with almost nothing. To the rehabilitation therapists who taught men with new limbs how to walk again. To the psychiatrists who insisted, again and again, that the mind deserved the same care as the body. Each of these people, in their own way, pushed back against the destruction of the war with the only tools they had: knowledge, skill, compassion, and an unshakable commitment to keeping people alive. Their work did not end the war. It did not stop the bombs or the battles, but it meant that more people survived. More people came home. More families stayed whole, or were at least given the chance to heal. That is not a small thing. In the long dark story of the Second World War, the people who chose to heal instead of harm were a steady, quiet light, and their legacy lives on in every hospital, every clinic, and every act of medical care that takes place in the world today. Sleep well. You've been in good hands tonight. Fact number 63. Among the many kinds of wounds that surgeons treated during the war, injuries to the face were in a category of their own. A man who lost part of his jaw, or whose nose had been destroyed by shrapnel, or whose eye socket had been shattered by a blast, that man faced something beyond the physical. His face was how the world knew him. It was how he knew himself. Reconstructing it required surgeons who understood not just bone and skin, but the person living inside them. The specialists who took on this work operated at the meeting point of surgery, dentistry, and what was just beginning to be called plastic surgery. Their procedures were long and staged. One operation to lay a foundation, another months later to build on it, another after that to refine. The patient lived inside this process for months or years, watching his face slowly become something he could recognize again. The best reconstructive units understood that no surgery could fully address what a man felt when he looked in the mirror and saw a face that was different from the one he remembered. So they combined surgical care with psychological support, sitting with patients, talking with them, helping them process what had happened. The work done at East Grinstead in England, at Walter Reed in the United States, and at other specialist centers laid the foundations of modern plastic surgery and of the understanding that a person's appearance and their sense of self are inseparable. Fact number 64. The medics who landed on the beaches of Normandy on June 6, 1944, had been told to expect roughly 25% casualties in the assault waves. At Omaha Beach, in some companies, the casualty rate in the first wave was closer to 90%. The medics who survived and were not themselves wounded worked in conditions that training had described in theory but could never fully prepare a person for. The water was cold, their equipment was soaked and heavy. Men around them were being hit while they moved between patients. Some casualties were too far out in the water to reach. and over again in the space of seconds, each medic had to choose which man to move toward, which man to leave. That decision was not made in the calm frame of a training exercise. It was made in the surf, with the sound of everything happening at once, and with the knowledge that both choices had consequences. The medics who survived D-Day and were interviewed afterward described it with a consistency that said something important. They did not use the language of heroism. They used flat, precise language, the language of people who had been required to function beyond anything they had understood themselves capable of, and who had done so, and who were still, years later, not entirely sure how. Fact number 65. Penicillin and sulfur drugs transformed the treatment of most wound infections, but there was one infection they could not stop on their own. Gas gangrene was different. It was caused by a specific type of bacteria that lived in soil and grew rapidly in the dead tissue of poorly cleaned wounds. By the time a surgeon could see the signs, the crackling sensation under the skin from trapped gas, the distinctive smell, the advancing edge of dying tissue, the infection was already severe. The only reliable treatment was surgery. Radical surgery. The infected tissue and everything around it had to be removed. And if the infection had reached a limb, amputation above the level of infection was often the only way to save the patient's life, and it had to happen fast. Before the toxins the bacteria were producing entered the bloodstream in quantities the body could not survive. Surgeons making this decision knew exactly what it meant. They were taking a limb to save a life. They made the decision with incomplete information, under time pressure, in the knowledge that delay was not neutral, that every hour of delay narrowed the margin between surgery that would work and surgery that would come too late. Penicillin helped support recovery after the operation, but gas gangrene required the knife first, and the antibiotic made the knife more likely to succeed. Fact number 66. Doctors knew, from the beginning of the war, that nutrition and wound healing were connected. A soldier with adequate protein, vitamin C and calories healed faster, fought off infection better, and recovered from surgery more quickly than one who was running on empty. This was not a surprising discovery. It was consistent with basic biology. What was less consistently appreciated was how quickly a soldier's nutritional status could deteriorate in the field. The combination of high physical demands, disrupted food supply, stress-related appetite loss, and the nausea that came with morphine in combat could produce significant nutritional deficits within just a few days. A man who had eaten well a week ago might be genuinely malnourished by the time he reached a surgeon. Recognizing this, military nutritionists worked to design rations that delivered adequate nutrition within the constraints of what could be packaged, carried, and prepared in the field. Vitamin supplements were added to some rations. High-calorie concentrates were developed for troops in forward positions. The underlying principle was simple. Nutritional support was not a luxury of the hospital ward. It was a component of medical readiness that needed to reach the soldier at the unit level before he was wounded, so that his body would be in the best possible condition to survive and recover if he was. The nutritional research produced by this effort directly shaped the discipline of clinical nutrition in the post-war world. Fact number 67. When Japanese forces captured the Philippines in early 1942, they took prisoner a group of American military nurses who became known afterward as the Angels of Bataan and Corregidor. There were 67 of them. They were held primarily at Santo Tomas internment camp in Manila for 3 years. Throughout that captivity, they kept working. They organized a nursing service for the camp's sick and injured. They trained fellow internees in basic nursing skills. They improvised equipment from whatever materials they could find. They maintained clinical records of the diseases and treatments passing through their care. Several contracted the very diseases they were treating: malaria, dysentery, dengue fever, and treated themselves while continuing to treat others. The supplies available to them dwindled steadily. The food grew worse. The uncertainty of not knowing when or whether liberation would come pressed down on all of them every day. They were liberated in February 1945. All 67 survived. Their professional competence had been tested in a way that no military nursing training had specifically prepared for. and they had met that test without exception. The records they left behind, patient logs, personal diaries, subsequent testimonies, remain one of the most remarkable accounts of medical practice under deliberate deprivation in the entire history of nursing. Fact number 68. One of the most practically useful innovations of wartime medicine was also one of the simplest. Someone realized that the standard military jeep, the small, rugged, four-wheel drive utility vehicle that could go almost anywhere, could be adapted to carry wounded soldiers. A purpose-built ambulance was better equipped and more comfortable, but it was also heavier, slower across rough ground, and unable to reach the forward positions where the casualties were. The jeep could go almost anywhere a soldier could go on foot. It could carry 2 stretcher cases, or 4 sitting casualties, and it could do so across terrain that would stop a larger vehicle cold. Jeep ambulances were used across every theater of the war, in the North African desert, in the mountains of Italy, on the Pacific Islands, across the fields of Northwest Europe. They reached positions under fire that no standard ambulance could approach. They navigated muddy tracks that became impassable to heavier vehicles in wet weather. They were driven in many cases by regular drivers given basic medical training rather than specialist medical transport personnel, which made them a flexible resource that could be deployed quickly and widely. Their contribution was straightforward and measurable. They reduced the time it took to get a wounded man from where he fell to where a surgeon could reach him, and in the brutal arithmetic of battlefield wounds, every minute of that reduction counted. Fact number 69. The German Army's medical services on the Eastern Front during the catastrophic winter of 1941 to 1942 were overwhelmed in ways that nothing in their previous experience had prepared them for. Casualties from frostbite, from the ongoing fighting, and from the beginning of the Soviet counteroffensive arrived at field hospitals at rates the system simply could not process. Surgeons worked for 20 and 30 hours without stopping. Anesthesia supplies ran low. Blood was unavailable. Instruments could not be sterilized quickly enough to keep pace with the volume of operations. The men who worked through this emerged on the other side with a clinical capability that no peacetime career could have produced, built on sheer volume of practice, on having made more decisions and performed more procedures under more difficult conditions than most surgeons would encounter in a lifetime. Some of them published accounts of what they had learned. Others carried it in silence. The knowledge was real, and it was valuable, and it was paid for at a terrible price, by the patients on the tables, and by the doctors who stood over them for 30 hours at a stretch, and by the system that had put all of them in that place together. The skill that came out of it could not redeem the conditions that produced it, but it existed, and it went on being used long after the winter was over. Fact number 70. Cholera moved quietly through the civilian populations of Asia during the war. In India, in Southeast Asia, in China. And the military tracked it carefully, because cholera in a military unit could destroy its fighting capacity within days. The disease spread through contaminated water, and the conditions of military campaigning in endemic areas created near-perfect transmission conditions. Large numbers of people moving across landscapes with unknown water sources, disrupted sanitation, shared wells and rivers. Allied forces deployed to the subcontinent were vaccinated against cholera before arrival, and the vaccination reduced the severity of illness in those who were exposed. The civilian populations through which those forces moved had no such protection, and the presence of large military forces, with all the disruption they brought to local water and sanitation systems, sometimes made things worse for the civilians living nearby. Military medical services observed this, documented it, and in some cases provided assistance, but they had not been mandated or resourced specifically to manage civilian public health at scale. The cholera that swept through civilian populations in the wake of military operations in Asia was one of the quieter, less visible medical consequences of the war's passing, not caused directly by weapons, but caused nonetheless by the vast disruption that the war carried with it wherever it went. Fact number 71. Among the psychiatric emergencies that military medicine had to manage, the acute psychotic episode presented a particular challenge in forward areas. A soldier experiencing a full psychotic break was simultaneously a medical emergency and an operational problem. His behavior was unpredictable. He might harm himself or others, and he needed to be removed from the tactical situation immediately. The forward mental health teams that Allied armies eventually deployed were primarily oriented toward combat fatigue, the more common stress reaction that could often be treated with rest, food, and supportive conversation close to the front. Acute psychosis was a different matter. It required sedation with whatever was available and rapid evacuation to the rear, where specialist psychiatric facilities could provide proper assessment and care. The gap between the initial sedation and the specialist facility, the back of an ambulance, a ward bed in a field hospital, a transit facility, was a nursing challenge that standard training had not specifically addressed. Nurses and orderlies managing sedated or disturbed patients in those transitional spaces were improvising, drawing on clinical judgment and personal steadiness in situations the training manuals had described only in outline. Their quiet competence in those difficult moments was an unsung part of the wider story of wartime psychiatric care. Fact number 72. Aircrew who flew combat missions face particular risks to their eyes. The blast of high-speed wind, the flash of weapon fire, the fragments from cannon shells, the intense glare of the sun at altitude. Standard flying goggles protected against wind but offered limited protection against fragments traveling at weapon velocities. Aviation medicine units tracked eye injury rates across operational squadrons and identified the pattern clearly. Eye injuries were among the most common and most functionally significant injuries sustained by aircrew in combat. The response was incremental but measurable. Improved goggles with impact-resistant lenses were developed and introduced during the war. They were not dramatic in appearance. They looked much like their predecessors. But their lenses were engineered differently, and the difference showed up in the clinical data as a reduction in the rate of serious fragment injuries to the eye among crews who wore them. It was the kind of improvement that attracted no headlines and required no battlefield heroism. Just careful analysis of injury data, methodical engineering work, and the organizational will to get a better piece of equipment into the hands of the people who needed it. The contribution it made to preserving the eyesight of thousands of aircrew was real, even if it was never celebrated. Fact number 73. One of the clearest examples of evidence-based change occurring in real time during the war involved the surgical treatment of colon injuries. At the beginning of American military experience in North Africa, the standard approach was primary repair, closing the perforation in the injured bowel and hoping the repair would hold. It often did not. The repairs broke down in the contaminated, inflamed tissue of battlefield wounds, producing a severe abdominal infection called fecal peritonitis, and men who had survived the initial injury and surgery died from the complication. The alternative, bringing the injured segment of bowel to the surface of the abdomen and creating a temporary colostomy, bypassing the risk of a breakdown, had been used in the First World War but had fallen out of favor. The evidence from North Africa was compelling enough that the military medical service issued a formal instruction changing the standard protocol to mandatory exteriorization with delayed repair. The instruction was distributed and implemented while the war was still going on. Survival rates for colon wounds improved in the Italian and Northwest European campaigns that followed. It was medicine doing what medicine is supposed to do, identifying what was working, identifying what was not, and changing course based on the evidence. The fact that it happened in the middle of a war, quickly enough to save lives in the next campaign, made it one of the more remarkable examples of institutional learning the conflict produced. Fact number 74. In the Pacific, fungal skin infections were a persistent and draining source of non-combat casualties. The conditions were ideal for them: constant heat and humidity, prolonged time in jungle terrain with no opportunity to dry clothing or footwear, contact with soil and water carrying fungal organisms, and the nutritional deficits that reduced the skin's natural resistance. Tino infections spread across feet, between fingers, into ears. Immersion foot, caused by prolonged exposure to wet conditions, left men unable to walk. Treatment required antifungal preparations and the drying of affected skin, which was almost impossible in the jungle environment where the infection had developed in the first place. Prevention was theoretically straightforward: regular sock changes, daily foot inspections, antifungal powder, but it required a logistics system that could reliably supply clean socks and powder to forward positions in adequate quantities, and a command culture that treated foot care as a military requirement rather than a personal preference. Where both existed, infection rates were lower. Where either was absent, the aid stations continued to fill with soldiers who were functionally impaired by conditions that a clean pair of socks and 5 minutes of attention each day could have prevented. It was unglamorous medicine, but the fighting capacity of entire units depended on it, and the medical officers who enforced it were doing something genuinely important. Fact number 75. Soldiers who wrote about their experience of being wounded almost always mentioned, somewhere in the account, the moment the medic reached them. It was a specific kind of moment, the arrival of someone whose entire purpose was to help you, who had come toward you through conditions that rational self-preservation would have argued against. The trust this produced was not a warm personal trust exactly. Many soldiers barely knew their medic's name before the emergency. It was something more fundamental than that. The knowledge that there was a category of person whose specific professional commitment was to come for you, regardless of the tactical situation, and who would do so if they possibly could. This knowledge shaped how soldiers fought. Men who trusted the medical evacuation system, who believed that if they were hit, someone would come, fought with a quality of willingness that might not have been there if that belief had been absent. Military planners understood this, at least implicitly. Medical capability was not treated merely as a humanitarian function. It was understood as a component of combat power, something that made the fighting force more effective as well as more humane. The medic running across open ground was not separate from the military effort. He was part of it in a way that connected the healing function and the fighting function more deeply than either side of that pairing usually acknowledged. Fact number 76. The ability to administer intravenous fluids, saline solution, glucose solution, or plasma directly into a vein was fully operationalized at the forward medical level for the first time during the Second World War, and its impact on survival from shock and dehydration was immediate and measurable. Intravenous fluids had existed in civilian medicine for decades, but using them in field conditions required packaged equipment and simplified technique that the standard medical kit had not previously carried. The development of sealed glass bottles with integrated giving sets, administration systems that could be opened and hung from a convenient point above the patient without specialist preparation, made intravenous therapy accessible to personnel with basic training. In the tropical theaters, where dehydration from dysentery or heat could become life-threatening within hours, this mattered enormously. In surgical patients, intravenous access was essential for anesthesia and blood pressure management during operations. The packaging and logistics that got intravenous fluids to forward positions in usable condition represented an engineering and supply chain achievement that the clinical outcomes depended on completely, but that the clinical accounts rarely described in detail. The soldier lying on a stretcher with a drip running into his arm was experiencing the result of months of work by people he would never know: packaging engineers, supply officers, logistics planners, whose contribution to his survival was as real as the medic holding the bottle above him. Fact number 77. Soviet surgeons operating at Stalingrad worked in conditions that should, by any reasonable measure, have made their survival rates worse than they were. They operated in the basements of contested buildings, by lamplight, with instruments that could not always be adequately sterilized, on patients who had waited hours or days in cold and privation before reaching a surgeon. And yet the outcomes they achieved, documented in the systematic records that Soviet military medicine maintained throughout the war, were better than the physical conditions seemed to make possible. They reflected extraordinary surgical skill developed through extraordinary volume of practice, and the specific adaptations that Soviet military surgical doctrine had made to the conditions of the Eastern Front. Soviet surgeons favored radical wound excision, the aggressive removal of all damaged tissue, more extreme than Allied practice, and based on the hard experience that inadequately cleaned wounds in those conditions were almost uniformly fatal from infection. The doctrine was right for its environment, even if it was more aggressive than evidence from other theaters would have supported. The knowledge exchange between Soviet and Allied medical establishments was limited during the war itself, and the full picture of what Soviet military medicine had achieved on the Eastern Front only became clear to Western observers after the fighting stopped. What it revealed was a medical system that had been pushed to its absolute limits and had found ways, somehow, to keep functioning. Fact number 78. In German prisoner of war camps holding Western Allied prisoners, the Stalags and Oflags, the medical services operated under conditions that were constrained but partially functional. German authorities generally permitted captured Allied medical officers to practice within the camps. The International Red Cross delivered medical supplies through the parcel system. Captured doctors organized sick bays in whatever space was available, maintained patient records, tracked disease rates, and negotiated with camp commandants for specific medical supplies. Some did remarkably sophisticated work within these constraints. One British medical officer at a camp in Germany maintained an informal psychiatric practice, seeing prisoners who were experiencing the psychological erosion of long captivity and providing counseling support that the formal German medical system had no interest in offering. The psychological challenge of indefinite imprisonment, the slow wearing away of purpose, identity, and hope, was a condition that the conventional clinical categories of the period had not adequately named or described. The prisoner doctors who addressed it were working at the edge of their training, applying clinical judgment to something that had no formal diagnostic label, in an environment where the tools available were essentially conversation and presence. It was medicine stripped to its most basic element, one person in difficulty, and another person who showed up and stayed. Fact number 79. Air evacuation. Flying wounded soldiers out of combat zones and back toward hospitals, developed at different speeds in different theaters depending on available aircraft and terrain. In the Pacific and in Burma, where distances were enormous and ground transport was often impossible, air evacuation became critical to achieving acceptable survival rates from serious wounds. The aircraft used were generally not purpose-built. They were transport and cargo planes adapted for the role, with stretchers fitted into the cabin and whatever medical equipment could be carried. The nurses who flew as flight nurses on these missions managed patients ranging from the stable and walking wounded to the critically ill, men on intravenous drips, on oxygen, in serious and fragile condition, in aircraft that were sometimes poorly pressurized, and that changed altitude in ways that affected patient physiology in ways the standard training had not specifically covered. Flight nurses developed the clinical protocols for managing patients in the air environment through a combination of formal preparation and direct operational experience. They figured out what worked by doing it, in real conditions, with real patients, on missions that sometimes came under fire. The specialty they defined in those aircraft became the foundation of modern aeromedical evacuation, a field that has saved countless lives in every conflict since. Fact number 80. When the atomic bombs fell on Hiroshima on August 6 and Nagasaki on August 9, 1945, the medical consequences fell into two distinct categories. The first, blast injuries, thermal burns, physical trauma from collapsing buildings, was comprehensible within existing military surgical experience, though at a density and scale that overwhelmed what remained of both cities' medical infrastructure. The second was not comprehensible at all. In the days and weeks after the bombings, survivors who had seemed to escape serious injury began developing a pattern of symptoms unlike anything in the clinical literature. Bleeding from multiple sites, hair loss, high fever, progressive weakness, and death. Japanese physicians treating these patients did not initially understand what they were seeing. It was radiation sickness, the consequence of intense exposure to the radiation produced by the nuclear explosions, and no medical training anywhere in the world had described it. American medical teams who reached the cities in the following weeks documented the syndrome systematically. The treatment available, supportive care, blood transfusion for the hemorrhagic complications, was inadequate for the most severely exposed, but the clinical documentation produced in the ruins of those two cities became the foundational literature of radiation medicine, shaping the development of nuclear medicine, radiotherapy, and radiation protection for every decade that followed. The science was built on an event that should never have been necessary to learn from. Fact number 81. The regimental medical officer, the battalion-level doctor closest to the fighting, navigated a tension every day that sat at the heart of military medicine. His obligation as a doctor was to the individual patient in front of him. The military system's requirement was for his assessment of whether that soldier was fit to return to duty. These two things were not always the same. A soldier returned to duty too quickly, whose wound was still healing, whose mind had not yet steadied, was being sent back into conditions that might kill him. A soldier retained in the medical system longer than his condition required was reducing the fighting strength of the unit, which translated, indirectly, into additional risk for the men who remained. Every regimental medical officer made this judgment many times a day, in individual consultations conducted under the pressure of an operational situation that was always present and rarely neutral. The judgment required medical knowledge and an understanding of the military context, the current operational tempo, the unit's strength, the nature of the duties the soldier would return to, integrated together in real time. In the logic of the evacuation chain, the regimental medical officer was the most consequential single clinical decision-maker in the system, because his decisions affected the largest number of patients at the earliest and most formative point in their care. Fact number 82. Chinese military medicine during the Second Sino-Japanese War and through the Pacific War period operated under conditions of material deprivation that made even the most under-resourced Allied medical units look well supplied by comparison. Years of Japanese invasion had disrupted China's industrial base and supply chains beyond the capacity to produce or import medical materials at anything approaching the rate the casualties required. International medical volunteers, including the Canadian surgeon Norman Bethune, who served with Chinese Communist forces before dying of blood poisoning contracted from an operative wound in 1939, brought skills and some supplies, but could not address the systemic shortage. Chinese military medicine responded with a combination of traditional practice, acupuncture and herbal preparations used alongside Western surgical technique, and mobile medical teams designed to function with minimal equipment. The outcomes were predictably worse than in better supplied armies. But the dedication of the medical personnel working within these constraints was, by the accounts of international volunteers who observed them, entirely equal to the dedication of their counterparts elsewhere. They were doing the same work, keeping people alive, reducing suffering, maintaining professional standards under pressure, with a fraction of the tools. The gap between what they had and what they needed was a measure of the war's inequality, not of the people working within it. Fact number 83. The North African desert created medical problems that the standard training manuals had not anticipated, because no major army had previously fought a sustained campaign in the Saharan environment. Heat stroke was the most immediately life-threatening, occurring when a soldier's body could no longer regulate its temperature under the combination of extreme heat and physical exertion. Treatment required rapid cooling of the core body temperature and fluid replacement, along with management of the serious complications, kidney failure, seizures, that severe heat stroke could produce. These resources were not always present where cases first appeared. Prevention was more manageable in principle. Adequate water rations, scheduled rest in shade during the hottest hours, monitoring for early signs of heat illness. In practice, the water ration was a logistics calculation, the minimum required to maintain operational effectiveness, which was not always the same as the minimum required for health. Soldiers new to the environment were the most vulnerable, and the acclimatization period of 2 to 3 weeks during which the body adjusted to the heat load was a period of elevated medical risk that the operational situation did not always permit the medical service to protect. The medical officers who learned to work in the desert developed a practical understanding of heat illness that had no peacetime equivalent and that served them directly in the Italian and later European campaigns. Fact number 84. The penicillin that reached Allied soldiers on the beaches of Normandy on June 6, 1944, was the end product of a supply chain of extraordinary complexity that had been built in the preceding months. The pharmaceutical plants in the United States, Pfizer, Merck, Squibb, Abbott, and others, had been scaling up the fermentation and purification processes since 1943. Each production batch had to be quality tested. The drug had to be packaged in ampoules that could withstand the physical handling of military supply chains. The labeling had to be clear enough for medics with basic training to use correctly in a field situation. The cold chain had to maintain the drug's potency from the factory floor to the hold of an amphibious landing craft. Each of these steps represented specific technical and logistical problems that had been solved in the months before D-Day by people who would never be on the beaches. The soldier who received a penicillin injection at a Normandy aid station on June 7th had no reason to think about any of this while the medic administered the drug, but the manufacturing and logistics achievement that delivered that drug to that moment was, in its own quiet way, as significant as the clinical discovery that had made the drug worth delivering. The distance between Fleming's laboratory in 1928 and that aid station in 1944 was crossed by thousands of people, most of them unknown. Fact number 85. The management of traumatic brain injuries in forward areas, penetrating head wounds, blast concussions, the closed head injuries produced by the near miss of large explosions, required the forward neurosurgical capability that was progressively developed through the war, combined with field assessment tools that could distinguish between different types and severities of brain injury quickly and reliably. The formal assessment scales that modern medicine uses for this purpose, including the Glasgow Coma Scale, had not yet been developed. Field medical officers used a combination of responsiveness testing, pupil reaction, and clinical judgment, and the consistency of these assessments across different observers varied considerably. Neurosurgical teams at forward army level developed their own protocols from experience, from the progressive standardization of neurological assessment that occurred across Allied armies during the war, was a direct precursor to the systematic work that produced the formal assessment tools of post-war neurology. The clinical decision that all of this assessment was designed to support, which patients needed immediate neurosurgical intervention, which could safely travel to more distant specialist facilities, which had injuries too severe for surgery to change the outcome, was the same decision that emergency neurological assessment tools were designed to support. The wartime experience of making that decision under field conditions shaped the thinking of the neurologists and neurosurgeons who built the tools that eventually made it more reliable. Fact number 86. The partisan medical service in occupied Italy, the network of civilian doctors, nurses and volunteers who provided care for resistance fighters operating in the mountains and cities, was one of the more remarkable informal medical establishments of the entire war. These were not military medical officers protected by the Geneva Convention. They were civilians performing a military medical function, subject to the same treatment as combatants if discovered. Several were arrested and killed. The care they provided ranged from battlefield wound management to the treatment of infectious diseases endemic to prolonged outdoor living, to support for the civilian populations caught in the fighting. They used farmhouses as surgical facilities. They moved their equipment on mule carts and bicycles. They maintained a clandestine care network with no fixed address, no guaranteed supply line, and no institutional protection. The medical volunteers who joined this service were accepting a level of personal risk qualitatively different from the risk accepted by any uniformed medical officer. Their work was simultaneously a professional and a political commitment. The act of treating a wounded partisan was also a declaration about which side of the conflict they were on. In conditions that made everything harder, they did what doctors do. They showed up. They treated the person in front of them. And they came back the next day and did it again. Fact number 87. British military psychiatry entered the Second World War carrying the complicated legacy of the First. The shell shock controversy of 1914 to 1918 had left the military psychiatric establishment with a dual obligation to take psychological casualties seriously as a genuine medical reality and to manage them in ways that served operational requirements. The approach developed for the Second World War combined forward treatment, brief rest, food and supportive care close to the front, with an expectation of recovery and return to duty, with a clearer understanding of the difference between acute situational breakdown and the more persistent psychiatric conditions requiring specialist care. The system was more humane than its predecessor and more effective in operational terms. It was built on the argument, made consistently by military psychiatrists throughout the war, that any soldier given sufficient exposure to combat could break down. That psychological collapse was a function of circumstances, not of character, and that treating it as a medical condition rather than a moral failure produced better outcomes for the individual and better results for the army. The system was not perfect. Some men were returned to duty before they were ready. Long-term consequences were not adequately tracked, but it represented a genuine advance, the institutionalization of military psychiatry as a recognized specialty, with a defined and legitimate function inside an institution that had not always been willing to accept it. Fact number 88. The 95th Evacuation Hospital was an American military hospital unit that followed Allied forces through North Africa, Sicily, Italy, and France, setting up in olive groves and ruined buildings, breaking down and moving, setting up again, across 3 years of continuous operation. The records they kept, patient logs, operative notes, outcome data, were maintained systematically throughout. What those records show is an organization that learned continuously from its own experience. Triage protocols were adjusted, surgical techniques were modified, supply management improved. Each change was a direct response to the clinical data the unit's own operations were producing. It was a model of institutional learning operating under the strongest possible incentive, the lives of the patients in the wards. The unit's record was a microcosm of what military medicine at its best looked like during the war. Not the dramatic heroism of the medic on the beach, though that was real and important, but the sustained, adaptive, data-driven collective effort by surgeons and nurses and orderlies and supply officers working together across years to save as many lives as the available knowledge and resources could save, in conditions that consistently demanded more than either. The 95th was one unit among many. The story it documented was the story of all of them. Fact number 89. When Allied forces entered the Netherlands in May 1945, they found a civilian population that had endured what became known as the Hunger Winter, a period of severe food shortage in the western cities caused by a German blockade combined with the harshest winter in decades. Malnutrition had reached levels that Dutch civilian medicine had not seen since the 19th century. Nutritional deficiency diseases, edema from protein deficiency, scurvy from lack of vitamin C, pellagra from niacin deficiency, appeared across the population. Allied forces brought food, but distributing it to several million people required a logistical organization different from feeding a military force, and the military supply system had to improvise. The medical supervision of nutritional rehabilitation was critical. Reintroducing adequate calories too quickly to bodies that had adapted to starvation could cause refeeding syndrome, a dangerous and potentially fatal complication that had been observed in the liberated concentration camp survivors. Military medical personnel and the Dutch civilian medical infrastructure that had survived the occupation worked together informally, each contributing what they had. The nutritional rehabilitation of the Dutch civilian population was substantially complete within months of liberation. It was one of many quiet post-war medical operations, unglamorous, unheralded, and entirely necessary, that the war's end had made suddenly, urgently required. Fact number 90. The blood banking system built to serve the Allied military during the war was transferred into civilian healthcare in the immediate post-war period, and the infrastructure it established continues to operate today. The cold chain logistics developed to move whole blood to forward surgical units in the Pacific became the basis for the temperature-controlled storage and transport systems that modern blood banks use. The donor recruitment and testing protocols developed by the American Red Cross for the military program became the foundation of the civilian voluntary donation system. The research into blood storage and preservation driven by the operational need to extend shelf life and reduce waste produced technical advances, improved preservative solutions, plastic bag storage systems that replaced fragile glass bottles that were directly applicable in civilian medicine. The men and women who had built the wartime blood supply program brought their expertise into the civilian institutions where blood banking developed in the post-war decades. Every unit of blood transfused in a modern hospital, and there are millions every year, moves through a system whose essential architecture was designed under the pressure of a world war, by people working against a deadline measured in lives. That architecture has been refined and improved in the decades since, but its foundations were laid between 1941 and 1945 in the urgent and unglamorous work of keeping donated blood alive long enough to save someone else. Fact number 91. Military psychiatrists who interviewed soldiers following psychological breakdown consistently identified a specific precipitating factor in a significant proportion of cases: the recent death of a close friend or well-known comrade. The loss was not just grief in the ordinary sense. It was the sudden, direct confrontation with the reality that the danger they all lived inside could take someone they knew. Someone specific. Someone whose face they knew. This disrupted something fundamental in the relationship to risk that most soldiers maintained in order to keep functioning. The implicit belief held against the evidence that the danger was real but somehow not fully applicable to them personally. Losing a friend made it applicable. Military psychiatrists developed psychological first aid responses specifically oriented towards soldiers who had recently experienced such a loss. Brief, focused conversations acknowledging the death, providing clear information about what had happened, and normalizing the emotional response as a human reaction rather than a sign of weakness or breakdown. These approaches were precursors to the critical incident stress debriefing methods that became standard in emergency services in the post-war decades, and they represented the beginning of a clinical understanding of grief in combat that the First World War's medical establishment had not possessed. The recognition that loss, specifically and directly experienced, was a medical event requiring a medical response, was a quiet but important step. Fact number 92. The medical planning for each successive Pacific amphibious assault incorporated lessons from the one before it. Tarawa in November 1943 had produced casualty flows that overwhelmed the initial beach medical capability, large numbers of wounded arriving in a very short time, in a location where medical infrastructure was at its least developed. The lessons were specific and actionable. Medical supplies were pre-positioned on dedicated landing craft that could be brought ashore early. Additional medical personnel were assigned to the assault waves. Beach casualty collection procedures were developed that could function in the surf. Naval medical resources on ships offshore were integrated with beach medical teams into a coherent treatment system spanning the water between them. Each subsequent operation, Saipan, Guam, Peleliu, Iwo Jima, Okinawa, built on the protocols refined in the one before. The cumulative improvement in amphibious assault medical outcomes across the Pacific campaign was measurable in the data, and it was a direct consequence of this systematic institutional learning. It was not dramatic. It did not involve individual heroism or breakthrough discovery. It was the slower, steadier work of an institution paying careful attention to what had not worked, making specific changes, and then measuring whether those changes had helped. In the Pacific, where the distances and the terrain left no margin for error, that kind of learning was as important as any surgical innovation. Fact number 93. The Second World War was, among other things, a vast and involuntary natural experiment in the limits of human physiology. The operational requirement to understand how the body performs under extreme conditions, at high altitude, in extreme cold, in extreme heat, under sustained sleep deprivation, under severe caloric restriction, produced physiological research on a scale and at a speed that peacetime funding and ethics would not have permitted. Altitude physiology research driven by aviation medicine produced the foundational understanding of acclimatization, hypoxia, and the physiological limits of performance at height. Cold injury research driven by the Eastern Front frostbite catastrophe and by the need to understand cold water immersion survival produced the data on which thermal protection standards for survival equipment were subsequently based. Starvation physiology research conducted through the study of liberated prisoners and concentration camp survivors produced the understanding of the metabolic consequences of prolonged severe undernutrition that informed the development of clinical nutritional support. Each of these bodies of knowledge was paid for at a cost that no ethical framework would have sanctioned as a research methodology. The scientists who documented the findings did not create the conditions. The war had done that. What they did was record, systematically and carefully, what those conditions revealed about the human body's capacities and its limits, and make that knowledge available to medicine for every decade that followed. Fact number 94. The nurses who served in General MacArthur's Southwest Pacific Command worked under a policy that kept them further from the front than nurses in other theaters were permitted to go. MacArthur maintained this policy consistently, reflecting his personal view that women should be protected from the most direct exposure to combat conditions. The nurses who served under it were, for the most part, frustrated by it. They understood, in the direct clinical terms of their professional experience, that the distance between them and the patients who needed them most was itself a clinical limitation. The care available to seriously wounded soldiers in forward areas was worse because the nurses who could have provided it were not there. The tension between MacArthur's protective instinct and the nurses' professional judgment about where their skills were most needed was a specific version of a broader tension running through the entire war between the military establishment's cultural assumptions about women and the wartime reality that women's professional capabilities in medicine were essential to military medical effectiveness at every level of the system. The nurses in MacArthur's theater served with full professional distinction. They did so while arguing, persistently and mostly unsuccessfully, for the right to be further forward, closer to the patients who needed them most. Their argument was correct, it was simply not accepted. Fact number 95. The regimental aid post was the most forward fixed point in the British and Commonwealth medical chain, typically located in a building, a cellar, or a dug position a few hundred meters from the front line. It was run by the regimental medical officer, working with a small team of orderlies, and it was the first place a wounded soldier reached after his own first aid kit and the combat medic who had treated him in the field. The procedures available were limited: resuscitation, wound dressing, fracture immobilization, morphine, plasma, and the assessment that would determine evacuation priority. The regimental medical officer made triage decisions here multiple times a day, in conditions of noise and pressure and incomplete information, working from training that had described the principles and experience that had taught him how those principles felt when applied to an actual person in an actual moment. The quality of those decisions, the accuracy of the evacuation priority assessment, the effectiveness of the initial wound management, shaped every outcome that followed. The entire chain of evacuation downstream depended on the judgment made at this earliest and most pressured point. The regimental medical officer who got those decisions right, day after day, under conditions that made getting them right very difficult, was doing something that the system depended on completely and that the system's formal histories rarely described in adequate detail. Fact number 96. When the atomic bomb fell on Hiroshima, approximately 90% of the city's physicians were killed or incapacitated. The medical response to the bombing was left almost entirely to the survivors, the doctors, nurses, and medical students who had been in the city and had lived through the blast. They began treating the injured with whatever materials they could find in the ruins of their medical school and the surrounding buildings. The injuries they encountered included the burns and blast trauma that existing medical knowledge could at least partially address, and the radiation syndrome, the bleeding, the hair loss, the progressive weakness that no existing medical knowledge had described. They were treating something they had never seen, with inadequate supplies, in the ruins of a city, while themselves experiencing the physical and psychological effects of what had happened. The accounts left by these surviving Japanese physicians and medical students are among the most important primary documents of the atomic age, not for what they reveal about the physics of the weapon, for what they reveal about its human cost, recorded in the clinical language of professionals who were simultaneously the bomb's victims and its first responders, doing what their training and their commitment required of them in conditions that were entirely beyond anything their training had prepared them for. Fact number 97. The management of pain across the entire arc of the war reflected the limitations of the pharmacology available and the specific ethical pressures of a medical system operating under military constraints. Morphine for severe pain, aspirin for moderate pain, ether for unconsciousness during surgery, these were the primary tools. Beyond them, the options were limited. Local anesthetics could numb specific sites. Nerve blocks provided regional pain control for extremity surgery. And working quickly, reducing the time a patient spent in the most painful phases of a procedure, was itself a form of pain management, practiced by experienced surgeons who understood that speed, done well, was mercy. The ethical dimension was present in every decision about the limited morphine supply. The soldier in severe pain from an abdominal wound had a clinical need for analgesia that was also in the presence of shock, a physiological complication. Morphine addressed the pain while suppressing the breathing simultaneously. The dying man beyond surgical reach had a moral claim on analgesia for comfort that competed directly with the claim of the man who might survive if the morphine was conserved. These decisions were made continuously, in seconds, without time for reflection. Modern medicine has moved far beyond these pharmacological limitations. But for every wounded man in every theater of this war, those limitations were the reality, and the medics and surgeons who worked within them did the best that their tools allowed. Fact number 98. The liberation of the Philippines in 1944 and 1945 presented Allied medical services with the full spectrum of war medicine simultaneously. Rescued prisoners from Santo Tomas and Los Baños internment camps were severely malnourished, suffering from nutritional deficiency diseases and the psychological consequences of years of captivity, requiring management entirely different from the treatment of combat casualties. Civilian casualties from the Battle of Manila, where Japanese forces deliberately killed large numbers of Filipino civilians in the final weeks of occupation, created a mass casualty event of a different character still. And all of this was occurring in a city whose medical infrastructure had been largely destroyed in the fighting. Military medical units that arrived in Manila found themselves providing different types of care to different populations simultaneously. Combat surgery, nutritional rehabilitation, psychiatric assessment, and emergency public health, in a city that was still partly burning. The adaptive capacity they brought to this convergence was the product of 3 years of accumulated Pacific War experience, applied to a situation that was both familiar in its individual elements and unprecedented in their combination. It was a test of everything that had been learned since the war began, administered all at once in a broken city where the need was vast and the resources were never quite enough. Fact number 99. The official military histories produced immediately after the war reflected the cultural norms of their era in their treatment of women's contribution to military medicine. The female contribution was described as supportive rather than central, the necessary background against which the male clinical leadership performed the primary work. This framing was not accurate. The women who staffed the blood banks were indispensable to the system's function. The laboratory technicians, overwhelmingly women, who worked in medical research establishments, produced the quality control data that determined whether pharmaceutical products were safe to use. The physical therapists who worked with amputees and spinal injury patients in rehabilitation centers were the primary clinical contact for those patients across months of recovery. The nurses who flew evacuation missions, waded ashore at invasion beaches, and worked night shifts in field hospital wards were not supporting military medicine. They were military medicine, performing at the level their training and commitment required, in conditions that demanded everything they had. The subsequent decades of military and medical history have progressively corrected the official record, restoring the full weight of women's contribution to a picture that is more accurate and more just than the one that was first published. It is a correction that was long overdue and that is still, in some respects, incomplete. Fact number 100. The medical lessons of the Second World War entered the post-war world through every channel available. Published papers in medical journals, institutional reform, and the return to civilian practice of the physicians, nurses and surgeons who had spent the war accumulating its clinical experience. The surgical innovations of the war, in neurosurgery, vascular surgery, plastic and reconstructive surgery, burn treatment, orthopedic surgery, were carried back into civilian hospitals by the surgeons who had developed them. The psychiatric understanding of acute stress, combat grief, and long-term trauma was taken back into academic and clinical psychiatry. The public health methodology developed for managing infectious disease in military populations entered civilian public health institutions. The blood banking infrastructure was converted to civilian use. The rehabilitation medicine specialty, the aviation medicine specialty, the emergency medicine approaches to shock and trauma. Each of these fields of modern medicine has a direct lineage to the war's clinical experience, carried forward by the people who had gathered that experience in conditions that peacetime medicine could neither replicate nor wish to. The transmission was not formal or ceremonial. It happened in ordinary ways, in the consulting rooms and operating theaters and lecture halls where the people who had been there passed on what they knew to the people who came after them. Quietly, steadily, and permanently. Fact number 101. The last fact in this collection is not about a drug, a procedure, or a surgical technique. It is about a quality that ran through all the others. The medics on the beaches, the surgeons in the tents, the nurses on the hospital ships, the stretcher bearers in the jungle, the prisoner doctors with their improvised instruments, the flight nurses in unpressurized cabins, the regimental medical officers in their cellar aid posts. All of them shared something that the records and the statistics only partially capture. They kept going. In conditions their training had not fully prepared for, with tools insufficient to the scale of the need, under physical and psychological pressures with no peacetime equivalent, they continued to do what their commitment had defined as their function: to keep people alive, to reduce suffering, to be present at the worst moment of another person's experience, and do everything that knowledge and skill could do to change the outcome. Some of the people they treated lived, some did not. The ones who lived carried the mark of that care for the rest of their lives, in surgical scars, in replaced limbs, in psychological outcomes shaped by what the war's medicine had managed to do in the hours following the moment they were hit. The ones who provided the care carried it too, in the memory of faces seen under the worst circumstances, in the knowledge of what they had been capable of when the situation required it and there was no one else. The medicine of the Second World War was not clean. It was performed in mud and blood and conditions of noise and danger and inadequate supply that the clean narratives of medical progress rarely describe. It was done by people who were simultaneously practitioners of a healing profession and participants in a vast machinery of violence, and the tension between those two roles was present in every triage decision, every amputation, every psychiatric assessment of a man whose breakdown the system needed to resolve quickly enough to send him back to the conditions that had produced it. And yet something else was also present, something worth pausing with here at the end. The medicine of this war saved lives that every previous war had lost. The combination of penicillin and sulfur drugs and blood transfusion and plasma and forward surgical capability and systematic triage and the developing understanding of shock physiology produced survival rates from battlefield wounds that were measurably, dramatically better than anything that had come before. A soldier wounded in the Second World War who received adequate medical care had a significantly higher probability of surviving than a soldier wounded in any previous conflict. This was not an accident. It was the product of accumulated scientific knowledge, applied systematically by people who understood that their job was to close the gap between what injury threatened to do to the human body and what medicine could do to prevent it. The individual stories in this collection, the medic crawling across Omaha Beach, the surgeon operating in a Stalingrad basement, the nurse continuing her rounds during a Japanese air raid, the prisoner doctor performing surgery with a blade made from a tin can, are not simply stories of individual courage, though they are also that. They are stories of a profession maintaining its essential commitment under conditions specifically designed to make that commitment impossible. The commitment was to the person in front of them, not to the war, not to the strategic objective, to the specific human being who had been hurt and who needed help. That commitment had limits. It was constrained by supply chains that ran out, by triage protocols that required some people to be set aside, by the racial segregation that determined whose blood could be given to whom, by the military necessity that sent men back to combat before they were ready, by the political decisions that left some populations without access to the drugs and techniques that could have saved them. The medicine of the war was human medicine. Brilliant and improvised and courageous, and also bounded by all the failures of the human institutions within which it operated. The men and women who received medical care during the war were, by and large, ordinary people in extraordinary circumstances. They were farmers and factory workers and students and shopkeepers who had been given weapons, sent far from home, and hurt in ways that the weapons and the distances had made possible. The care they received was the effort of other ordinary people. Doctors who had been in peacetime practice, nurses who had trained in city hospitals, scientists who had worked in university laboratories to apply everything they knew to the problem of keeping them alive. That effort was imperfect. It was sometimes too late. It worked, often, with insufficient tools. It was administered in conditions that were themselves dangerous by people who were themselves afraid. It was also, taken as a whole, one of the most remarkable collective achievements of the entire war. Quieter than the battles, less photographed than the landings, largely invisible in the strategic narratives that history tends to tell. It happened in tents and cellars and ships and jungle clearings, in the small, concentrated, consequential space between a person who was hurt and a person who knew how to help. That space is where this collection has been. It is a good place to rest, sleep well,